All right, so we're going to start today with thorax and talk about some bone and joint disorders, fractures, how we deal with those in the physical therapy world, and kind of what comes along with those type disorders. Then we're going to go into knees, and we'll talk about the shoulder girdle. That's what I was trying to say. I can't speak today. The lecture for yesterday and then the lectures I uploaded last week are uploading right now. I'm watching them go. The lectures I uploaded last week or created last week evidently are like 4 gigs, so they're taking forever to upload. So we're going to talk about bone and connective joint disorders and stuff like that. So we have a couple different disorders that we talk about when we deal with these things. We commonly talk about arthritis. And overall, who's going to get arthritis in this country? Who's susceptible to arthritis? Yeah, elderly. More importantly, all of us, right? We're all going to have some form of arthritis eventually. Some of you have it now, right? Yeah, some of you have it now, and there are different types of arthritis you can get. You know, you've got your general arthritis, you have osteoarthritis, you have, rheumatoid arthritis, you have stuff like psoriasis, which is just another form of arthritis. It does make you sad, right? Depending upon what kind of sports you played when you were younger, predisposes you to arthritis of specific joints, right? I know Hector plays soccer. I can pretty much predict with pretty good accuracy that eventually down the line, he's probably going to have arthritis of the knees and ankle. It's just going to happen because overall his body is designed to slowly break down. He's not made to live forever. I'm sorry, Hector. I have to tell you that. Right, yeah. And it's amazing. And you have arthritis. You find out when you start getting to my age, when it takes you 5 to 10 minutes just to get out of bed. You're like, oh, God, yeah, okay. Yep, I think I've got that joint. Yeah, I still have that joint. So you have arthritis. The other thing you can get is arthrosis, which is a limitation of the joint without arthritis. And this comes into play when we talk about stuff like frozen shoulder or when you get bone spurs. Right. See, 10 years ago, Hector, you probably would have got up the next day and been able to play another 3 games. It's just that over time, our bodies just don't like it, right? They start breaking down. Overall, one of the things that affects us as a society and is really affecting us right now is just overall impaired mobility. And when you look at where we are right now as a country, I think about it looking at that, or listening to that, the conference that I was just listening to. We've created a double-edged sword here in the United States because, number one, we keep saying to people that what they've got to do is they've got to move more, they've got to move more, they've got to move more. And now we're telling people, well, yeah, you've got to move more, but stay away from each other. So you've created the ultimate excuse for people not to move, right? So you've created the ultimate excuse for people that need that little bit of an excuse of why they're not exercising to not exercise. Because now, the CDC says I'm not supposed to exercise because I can't get next to people. Well, great. It doesn't mean you can't exercise, right? I go out and I run every morning and I just avoid people, kind of like I do normally. I don't know. But we have, with the impaired mobility, then comes the cascade effect, right? Impaired muscle performance happens. Overall, as we get older and older and as we do less and less, our muscles start performing less effective. Like Hector said there, he's still noticing he's sore, right? The muscles aren't recovering as fast as they used to. And then balance, right? That's when you start noticing problems happening in your balance, that's when the cascade really starts kicking in. Because we all have this fear of falling, because we know if we fall, bad things can happen to us, right? We can fracture our hip, we can fracture our wrist. We can just become black and blue all over, right? Overall, that happens. And that leads us to overall functional limitations. We start limiting what we do. I was reading about yesterday, I think it was I'm trying to think, I don't know if it was Apple News or what I was reading, but it talked about the average American went from a shower every other day to a shower every 4 days with the pandemic. So he's like, so true, right? So that's impaired function, right? You're like, some of you are like, but you got to think about that. Some of you then probably are like, no, I'm showering every day. I mean, that's actually functional. But think about that for just a second, right? So if we have, like Kelly saying, ew, I mean, she's probably showering every day at least. But if she's showering every day, that means we've got somebody out there that's not showering every 8 days. Because the average is 4, so to get to that average of 4, you got to have somebody that's at 8 as well. Somebody, Chad. Isn't it always Chad? I'm just saying. So you kind of think about that. What kind of a functional restriction does that put us in? I don't know. Like, if I'm not showering every 8 days, I'm probably not hanging out with people. I don't know. Maybe they are. Maybe it's proven to us that we don't need to necessarily shower 3 times a day. I have a friend that did that before and is now realizing, hey, maybe I don't need to shower 3 times a day. I don't understand showering 3 times a day. I don't, but whatever. Whatever floats your boat, buddy. So, rheumatoid arthritis. What is the difference between osteo and rheumatoid arthritis from a pathology side? You guys had pathology last semester. I know you learned some stuff. Right. Osteoarthritis is primarily bone and joint, where RA is autoimmune. Exactly. That is a key thing. That means, what can a person do to prevent from getting rheumatoid arthritis? Nothing. Right? Maybe limit their exposure to radiation, stuff like that. But overall, nothing. They can't stop themselves from getting rheumatoid arthritis. Talk to somebody that's got something like psoriasis once. They would really love to not develop the signs of rheumatoid arthritis. But unfortunately, that's not in their cards. They don't have the ability to stop that. They want to. They'd love to stop it. But unfortunately, the body just says, we've got a kicked up immune system, get at it. Again, I focus a lot of this from living so many years with my ex-wife. The rheumatoid arthritis she had and seeing the crippling effects it had on her were just amazing to me. I mean, Monday, she can be gung-ho and I got to be ready and get rid of my own osteoarthritis and be ready to run out the door and go do stuff. To Tuesday, I'm carrying her back and forth to the bathroom. Right? It's amazing how debilitating rheumatoid arthritis is for people. Have any of you ever seen a person that's got really bad rheumatic hands, where the rheumatoid arthritis is just so horrible in their hands? Their hands look like, like a witch hand almost. They're all gnarled and, right? It's bad. And that person can't necessarily stop that. Right? And once you get your hands kind of gnarled like this, think about that, just the stigma alone, right? Little kids see a guy coming at them with gnarled hands. Come here, little boy. I want a hug. It doesn't necessarily, that was a really bad voice, doesn't exactly promote, social interaction, right? But with rheumatoid arthritis, you're going to have these peaks of active disease and lulls. And they can be as much as every other day. When they're in that active inflammatory cycle, a lot of times we want to think about, I keep having this one spot on my glasses that's driving me nuts. A lot of times we think about treating them almost like a normal acute care patient, right? Rheumatoid arthritis isn't the same as osteoarthritis. When osteoarthritis goes into an acute flare, you get that cytokine reaction, and you get the histamine reaction where you get a standard kind of inflammatory effect. With rheumatoid arthritis, the body's already inflamed. It just is. So they've lived in that state of inflammation. It's just now, the shoulder joint's getting attacked. So the first thing we have to do is talk about patient education, right? When their joints are hurting, they have to protect those joints. That is the body saying, hey, pay attention here because something's not right today, right? So if they've got pain in their hip, think about some of the things they might kind of try to avoid, right? They might not walk as much. They may want to protect that hip a little bit more. They may get an assistive device to help them walking. The main idea is energy conservation. You're going to find as we go through not only this semester, but next semester when I talk about neuro, one of the number one jobs of PT is energy conservation. When we have rheumatoid diseases, when we have neurological diseases, the patients need to learn to respect their fatigue levels and know their limits. Because when they have these autoimmune disorders, if they don't understand what their limits are, they can push past those limits and end up in a position where they're down for days. Same with MS, exactly, right? That's why I said talk about neuro conditions, right? Again, I'm going to use my wife as an example. There was a summer, probably before most of you were born, we went to this place called Kings Dominion in Virginia, which is a huge amusement park. Think along the lines of, Universal Studios and stuff like that, but in Virginia. It's owned by Paramount. But I remember we went and she had a really heavy intolerance to heat with her condition. And when we got there, it was warm. It was about 87 degrees, but 90% humidity, which means it felt like 1,000 degrees outside. And then as the day went on, the temperature kept climbing and climbing and climbing until it was 105 and 95% humidity. And I don't know if any of you have ever been in that condition, but that kind of feels like you're walking through soup, is the best way I can put it. Like hot soup. And she kept saying, "Oh, I'm fine, I'm fine." I would keep going, "Come on, I'm fine, I'm fine, I'm fine." And about 3 o'clock in the afternoon, I had her younger sister and her younger sister's brother with me. About 3 o'clock in the afternoon, I started noticing neurological symptoms with her. She was getting twitches going on. She was starting to stumble when she was walking. And at that point, I called it. I'm like, "We're done." And you'll find that a lot of these amusement parks are not designed for medical emergencies. We were in one part of the park and the medical facility was quite literally almost a mile and a half on the other side of the park. They had nobody in the general vicinity we were for a medical emergency. There no wheelchairs, no nothing, no. So I had to literally run a mile and a half through soup to get a wheelchair so we could wheel her out and potentially get her to the hospital. She ended up having a heat stroke from it. Didn't respect her limits, right? And then that heat stroke caused all kinds of other neurological problems down the line. So that's the thing we have to teach these patients is, look, you need to understand if your body's telling you you're too hot, you're too tired, respect it. Listen to your body. Your body's telling you for a reason. You also do still have to temper that with, I still have to do stuff. But they have to kind of listen to their body as well. In order to kind of open up those joints in the hands, the wrists, the elbow, the shoulder, we kind of are going to do those grade 1 and grade 2 mobilizations. And notice I put glides behind it. And there's a reason for that. I talked briefly about mobilizations, but I didn't talk about glides. And there's a reason for that. Mobilizations and glides are the same thing. Literally the same thing. The difference between a mobilization and a glide is a mobilization is something a PT does. Typically, glides are what PTAs do. And the difference is a mobilization has assessment while they're doing it, where a glide is just doing the joint mob without actually assessing it. That's the way they got away with it in Pennsylvania. Because remember, the APTA says PTAs can't do joint mobs. We're not allowed to do any, not even grade 1s. So Pennsylvania said, you know what? We respect that. We're not going to let PTAs do joint mobs. You can do joint glides. Well, what's a joint glide? Well, a grade 1 is where you start at the very beginning, you just kind of oscillate. So a joint mob. Well, no, you're doing a glide. Okay. And that was the way we documented things. Instead of saying that PTAs were doing joint mobs, we did joint glides. And they wrote it into the bill or their laws, and PTAs were able to do joint glides. It's decaf, by the way, before anyone yells at me. Exercise. They should do active range of motion as much as possible. This is where Tai Chi comes in really heavily, right? Tai Chi is great for patients with RA because high velocity movements, not so great for RA, right? Running, jumping, plyo, CrossFit, stuff like that, not so great. It kicks up the symptoms. But really kind of slow motion, full range of motion of the joint is really good for it. And then functional training, modifying ADLs, right? How can we modify some people's ADLs? Well, we can give them an assistive device to walk with, right? The point of an assistive device, so something like a walker, crutches, loft strand crutches, anything to that effect. The point of that assistive device is to provide compensation and energy conservation. So if we provide them with a walker that provides them with a little extra balance when their balance is off kilter, that makes them feel safer, and that will promote them doing more actual functional activities. And that's important. Providing them with a reacher, right? Reachers are those grabbers that they can grab everything with that might be on the floor or way away, are really important for those patients because what are they afraid of? They're afraid of falling. So now if I can use a grabber and grab something on the floor and I don't have to do a one-legged lift, right? A golfer's lift, it saves me the chance of falling. Not only that, but grabbers are great because then you can grab a hold of your grandkids and yank them to you too. But so all that kind of comes into play. How can we modify their ADLs? What kind of modifications could we possibly make to their household that could make their life easier? You know, we haven't talked a lot about ADA stuff yet, but what kind of stuff can we make to their household that might make their life easier and help with their ADLs? What about in the bath? What can we add? Grab bars, good, right? One other thing, what about a seat? Right? Yep, we can do home assessments. Absolutely. We're going to talk about that in 5th semester. Non-slip pads for the shower. Fantastic. Get rid of the tub. That, you know, as bad as that sounds, and I know all of you are going, oh man, if I got rid of my bathtub, I'd hate life. Well, they usually have one person that says that. My bathtub is where I hide from my kids. Motorized stair lifts, right? Good. Keep them from going up and down the stairs so much. Something as simple as the biggest thing that as a home assessment that I do, there we go, right there. Get rid of rugs. Throw rugs are the bane of old people's existence. And so throw rugs and also animals, I hate to say it. Yep. Yeah, they do love their throw rugs. I don't know what it is. Once you get to like a certain age, and I saw it in my ex-in-laws. Like, again, my parents passed away in 2001, 2002. So, you know, this is one of the advantages of anyone ever dating me is I legitimately have no real family. So there's no fighting for Christmas anymore. But I saw it in my in-laws, man, like they got to a certain age and all of a sudden throw rugs started showing up all over their house. And I'm like, what are you doing? Why do you need a rug on top of a rug? They're like, well, to keep traffic down over that rug. You just created yourself a tripping hazard. And sure enough, like 2 weeks after getting the throw rug in the living room, my mother-in-law fell. She tripped over the rug. And then they got one of the, what I call the little yappy doggies. They got one of those. And then that yappy doggie is running between her legs everywhere she's going. That kind of stuff happens, and that causes patients to fall. They've got to be aware of this type of stuff. Now, I'm not saying that ESAs are not good. I'm not even going to get into the topic of emotional support animals because that will just suck the life out of my soul. But they can be beneficial. You know, I would say if you're going to get an emotional support animal, just get a cat because at least a cat's not going to lie to you about wanting to kill you. So those kind of things, we can make changes to their homes. We can add a ramp and take away a step, right? Add a ramp to their front porch. Get couches that are a little bit higher up so they don't have to sit in those lazy boy recliners that go all the way back and you're sucked in them for life. There are all kinds of changes we can make to these patients' homes and help them. And yes, we can do home assessments. We're not evaluating a patient at that point. That's what's kind of nice about a home assessment. What we're doing is just going in and seeing, okay, where are my problem areas at? Right? We can do work assessments. We can do home assessments. There have been plenty of times where when I'm at the hospital, you know, especially because most people don't want to do home assessments. Why do we not want to do home assessments? Because you have to drive. You know, until you get there, you have to go into people's homes. You don't want to go into raised toilet seats. Yes, and people are gross. There, exactly. Right? But I'll gladly go do a home assessment. I'm getting paid the same rate to go do it, and I don't have to deal with people. I'm okay with that. Again, don't like people. So treatment approach is the main thing with rheumatoid arthritis is preventing those acute flares. And when I say acute flares, I'm not talking like, oh, look, they're in an acute flare. No, acute flares are where that disease kicks up where they can't do anything. So to do that, we're going to protect their joints. Joint splinting is really important for patients with RA, right? Getting their joints, when they're stuck in this position, to go back out to normal functioning position happens with splinting. You know, hand therapists are great for that. I can't stress enough how great they are. Assistive devices, environmental adaptations we just talked about, right? Flexibility and joint strength. We got to stretch these patients. These patients have to be stretched, but within tolerance of their joints. You're going to find if you've got a patient that with gnarled hands and you stretch their fingers out, they feel different than other fingers. They're not like your normal, like right now, if you guys take your fingers back like this, you can feel that firm end feel. Your body's telling you what. For them, you're going to get here and it's going to feel like a bony block. You're like, that just doesn't feel right. Well, we got to stretch them within their limitations, right? Low and slow stretching is really important for these patients. For cardiopulmonary endurance, no impact activities or low impact activities. That means no running, right? As much as a rheumatoid arthritis person might want to run, running is kind of contraindicated for patients that have RA. When they start running, they're kicking up every time you run, especially if you run long distance. So you run over the 5Ks, your 10Ks, your 15Ks, your marathons, stuff like that. When you run those long distance runs, your body is going into a phase of inflammation. And for those of you that do run, you kind of can feel this, right? Because when you get to a certain point, your body goes into that runner's high, right? You start running, and all of a sudden, you know, all the soreness, all the achiness, all the stuff about your body kind of goes away and you get that runner's high. Well, really what the body's doing at that point is going into inflammation. And it's releasing your natural opioids to try to counter that inflammation. We don't want that with patients that have already existing inflammation. We got to calm it down. So getting them to do stuff like, that's all I'm saying. So if you're healthy, it can be fine. But when you've got chronic inflammation, getting that runner's high can be a sign that you're pushing yourself too far too. So, you know, it's just like anything else, right? Having a high blood sugar once or twice, yeah, it's not going to, you guys eat a huge piece of chocolate on chocolate fudge cake, you know, the triple fudge cake. Why triple and not quadruple fudge? Because there is no fourth fudge. When you eat that piece of cake, you're going to get that sugar high. That doesn't mean that sugar high is bad for you. What that tells you is, okay, well, I a little overdid it. So psoriatic arthritis is very similar to rheumatoid arthritis. And that's the main thing I would say with that is when you're running, to be careful. Listen to your body. Getting the runner's high consistent, again, like I said, consistently not good, because when you get it, say you do that every day, you're getting to that point where you're getting that runner's high. Every day you're putting yourself in that state of inflammation. And if you have psoriatic arthritis, think about it, your body's already in a state of constant inflammation. So putting yourself in that state of constant inflammation constantly is bad. Did Dr. Sokel talk to you guys about running and what happens when you're sick and you run? The studies show that if you're sick and you run like a 5K or under, it's actually really good for your health. Under 5K, you know, especially like really short runs, kick up your body's natural immune system. But once you get into those long distance runs, you actually suppress your body's immune system. And so that's why a lot of people that run these marathons, the next week, guess what? They're sick. On top of the fact they just ran a marathon with 30,000 other people that have germs, they've already suppressed their immune system while they're running. So that's a double-edged sword there, Adrian, is that could suppress the immune system and maybe tamp down your psoriatic arthritis. But you're putting yourself in the inflammation, which may kick up your psoriatic arthritis. So it's a listen to your body type event. And I'm not here to, you know, I'm not an exercise physiologist and can't 100% say, oh, no, don't get the runner's high all the time. What I'm saying is when you push yourself that far all the time, you're getting into that inflammation phase, and you just got to be careful if you've got, stay on the couch. Exactly. Got it. That's what I'm saying. All right, DJD. Again, another disease we're all going to get. Our joints are just going to degenerate, right? We're all degenerates. When you have degenerative joint disease, we're typically talking about people that aren't in that older phase, right? A lot of times you're going to hear two different terms. You have DJD and DDD, right? The triple Ds and the DJD. DJD is degenerative joint disease. DDD is degenerative disc disease. Usually one will go hand in hand with the other. If you have a degenerative disc, you probably have degenerative joints. If you have degenerative joints, you probably have degenerative discs in your back. But knees are really common for DJD, right? Hector said he's still feeling it a day later. He may have a little bit of wear and tear on his knees. That's just the way it happens, right? With the patients, we're going to have to teach them what their conditions mean, right? Here's the deal. If you have DJD, as long as you manage it and you manage the pain, you can be fairly functional as long as you pay attention to the point where that degenerative joint disease starts affecting your everyday life. Then it may be time to think about some surgery or something like that, right? Pain management, mornings are the worst for patients that have DJD. And I'm going to speak from example. I'm not joking that 5 minutes in the morning, I'm like, okay, yep, there's a hip. Okay, that's moving. Okay, do I have a foot still? Yep, I still got a foot. The only thing that I have beneficial is that I don't feel the DJD of my left arm because my left arm's like, yeah, I'm good. You can't feel me, but I'm busted up. So in the morning, it's kind of good for those patients to get up and move a little bit, right? On an average, 5 to 8 minutes is normal for a patient that has DJD or rheumatoid arthritis or osteoarthritis to get moving in the morning. It's kind of normal. Late stages, once you kind of get later in the stages of having DJD, you often get pain at rest, meaning you stop, you're like, okay, I'm hurting too much, I got to stop doing stuff. And then when you stop doing stuff, your pain gets worse. You're like, wait a minute, I'm resting, why am I still sore? Well, it's because the bone and the joints are just destroying themselves. And now you've got nothing to it, right? So we're going to start with assistive devices like raised toilet seats, walkers, shower chairs, resistive exercises. These are you would not think of this, but when you have a joint that's breaking down, the only thing that's holding that joint truly together at that point are the muscles and tendons and the ligaments. So the more you strengthen them, the more you're going to be agile, mobile, and hostile, right? So strengthen those joints up. My knee is just my left knee is absolutely destroyed. Done. It's shot. So I purposely work my quads and my hamstrings and all my associated muscles around the knee so that my knee is solid despite the fact that it's not solid. I rely on my muscles and my tendons to hold my knee together more than the joint itself. Stretching and mobilization, they must do self-stretching. If you've got degenerative joint disease, you got to get them doing self-stretch. They want you to stretch them constantly and stretch them a little bit yourself. Not a bad idea. But they've got to do stretching at home. They've got to get in a stretching regimen. On average, how many of you guys stretch 15 minutes a day? 10, okay. That's better than average. Yeah. Stretching as speak, fantastic, right? Good. I'm glad that's really beneficial for your health. A lot of studies have shown stretching 15 minutes a day is really good for your overall flexibility, mobility, and your ability to move around. I've gotten out of the habit of it. I tend to stretch I'm more along, like Renee said, I'm more like the 5 minutes. That's where I'm at usually. I got to get better at it. But when I was in the martial arts, that was one of the things. So in my martial arts class, when I was back in the day and I was young, our classes were 2 hours long. 30 minutes of that class was going to get in. 30 minutes of that class was dedicated to stretching. And I was amazed at how much healthier I felt back then compared to where I feel now. And I probably should get back to that. I really wonder if that would make me feel a little bit better than I do now. Maybe. But old habits are hard to break, right? Hold the splits, exactly. Cold stretches, here's the deal is, what is a cold stretch? Because when you're stretching, as long as you're not, you're not torquing it too much, right? Not torquing it, you're warming the muscle up. So I don't totally like the idea of cold stretch. The only thing I'll say is you don't want to drop in. Yeah. There is a huge difference in warming up, right? So doing a little bit of calisthenics before you're stretching, good. But everything I've seen, just stretching in general is good. You will get better results if you're warmed up, right? But who's to say your warm up isn't just putting a hot pack on? That can warm you up just as well. You know, it's not as active, but we do that with patients all the time, and patients get addicted to those hot packs. It's really ridiculous. Balance activities, non-traditional low-impact balance activities are really good for these patients. Again, Tai Chi, I can't stress that enough. Aerobic conditioning, low impact. The main thing with degenerative joint disease, no plyometrics. Right? And when I talk about plyometrics, I'm talking about exercises that have a very, very kind of bursty attitude. Right? Jumping, you know, 24-inch box jumps in CrossFit. Why? Those type of things. Plyometrics, you got to limit down. And sometimes that can be really difficult because maybe you have a patient like Hector who's played soccer all his life. And now he comes into you and the doc's diagnosed him with bilateral degenerative joint disease of his knees. And he's like, but I'm so used to going out and playing soccer every day. And you have to tell him, you know, okay, well, maybe we need to step it back to once every other day. Mainly to keep your joints from breaking down, because once you start getting that degenerative cycle, it just cascades, right? I know eventually my knee is going to need a replacement. I'm going to put it off as long as I can, but eventually it's going to need a replacement. I'm old. I'm breaking down. Eventually you guys will be caring for me. So myofascial pain syndrome and fibromyalgia. Let me take a deep breath here. Okay. Fibromyalgia is a real condition. Don't let other people say it's not. A lot of people believe that fibromyalgia is a made-up condition, but that doesn't mean that everyone that says they have fibromyalgia actually has fibromyalgia, right? So here's kind of the difference between myofascial pain syndrome, MPS, and fibromyalgia, right? We're going to talk a little bit about both. Fibromyalgia, you have tender points at specific sites, and I love that they spelled sites wrong. I just noticed that. In the body. That's fantastic. Good job, book. In myofascial pain syndrome, it's typically trigger points in the muscle. Fibromyalgia, the pain doesn't refer. In myofascial pain syndrome, and you talked about this a little bit with Dr. Johnson, you get referral pain syndrome, where maybe the pain's in your arm, your muscle, your bicep, but the pain is felt elsewhere. Usually in fibromyalgia, you don't have tight muscles. In myofascial pain syndrome, you do. Fibromyalgia, a lot of times the main complaint of fibromyalgia is I'm just so tired, I'm fatigued. With MPS, the main problem is pain. So we're going to talk a little bit about both of them. So fibromyalgia has a prevalence of about 2% in the population. So that's still pretty significant, right? If you think about that, 2% of the population is pretty high. Characteristics, some of the diagnostic criteria in order to be diagnosed officially with fibromyalgia. Now, when I say officially, this is going to a rheumatologist and being diagnosed with fibromyalgia. Because some primary care physicians will just say, yep, you've got fibromyalgia. Why do they tell the patient they've got fibromyalgia? Why would a doc just say, yep, you've got fibromyalgia? Prescribe something, give them pain meds. Honestly, the main reason is to get that annoying person out of the office. Because a lot of these people that are suffering in chronic pain just want a diagnosis. That's all they want. Because they don't understand pain, right? They just don't grasp why do I hurt? You know, people that have these chronic pain syndromes, especially fibromyalgia or myofascial pain syndrome, there's nothing they can point to. It's not like they're saying, oh yeah, yesterday, you know, Hector took me out and we played soccer for 4 hours. That's why I hurt, right? No, they just get up in the morning like, oh my God, I feel like I'm dying. Why does this happen to me constantly, right? And then you get the effect of family members where, you know, family members are like, well, stop acting like a baby, all this stuff. So with fibromyalgia, There has to be an underlying physical or mental trauma event. So that's number one diagnosis criteria. So there has to be some sort of an event that triggered the onset of fibromyalgia. Now, this can be psychological abuse. This can be physical abuse. This can be a car accident. This can be a trauma to somebody in the family that ended up causing you mental disorder, right? There has to be some form of a trauma to trigger it. The pain has to be in the musculoskeletal order, right? So if the patient is saying, I've got burning, numbness, and tingling, that's not musculoskeletal in order. What does burning, stinging, tingling indicate? What type of pain? Very good, nerve pain, right? It's neuropain. That's not a fibromyalgia symptom. How do you describe musculoskeletal pain? Yeah, dull, achy, right? Maybe a little throbbing. I just feel, right? That's kind of what a musculoskeletal pain. You guys have had that, right? You've all had it where you've done too much the day before, and you get up the next day and you're like, why did I do that? Some of you do that on Friday nights. You wake up Saturday morning like, why did I do that? That's a different type of pain, right? But for the most part, musculoskeletal pain is just that nagging pain. So now imagine, I like using Hector because he already told me he's kind of sore. Imagine Hector having that pain that you had the day after you did all those soccer games every single day of your life without a reason. Right? Just imagine what that would be like to you. Where if you woke up every day and your legs and your quads and your hamstrings are just screaming at you every day. That's what somebody with fibromyalgia goes through. They have to have 11 out of 18 tender points. I have the tender points coming up here. And then we have to kind of look at what triggers it. Most of the times, it's not even exercise or something that triggers fibromyalgia kind of symptom. What it is weather triggers it, right? This area is really good for patients with fibromyalgia. Why is it? Well, our weather doesn't change, right? It's annoying, it's hot. We have two seasons, right? We have summer and getting ready for summer. Those are our two seasons. Back where I'm from, where we have two seasons, hot and cold, because we used to have summer, spring, fall, winter, all that. Now we've just got hot and cold. Those are the two seasons in Pennsylvania now. That causes all kinds of problems with patients that have fibromyalgia and rheumatoid arthritis and psoriatic arthritis and everything like that. Weather is a contributing factor, primarily that barometric pressure, right? And I know that some of you in this class that might be a little bit older understand that, right? I start telling you the barometric pressure is going up or down. Can you already start feeling it in your bones and joints when you think of just thinking about it? Right? You ever get that person that tells you, it's going to rain today. I can tell you it's going to rain. And you're like, no, it's not. You're silly. And 20 minutes later, it's raining outside. Right? Because barometric pressure comes into play with our joints. Physical mental stress, anything that triggers the body can trigger them to go into a flare. And then prolonged immobility. This is the funny part. Because I've got fibromyalgia, I'm going to stop doing things. Because I stopped doing things, I have fibromyalgia. Because I stopped doing things, now I have more fibromyalgia. My fibromyalgia is making me stop doing things. So you end up in this really vicious cycle where it just makes the disease worse. So we have to come into management. We have to convince them it's okay to hurt. And we're going to have a class coming up in 5th semester where I talk about chronic pain management. And I approach chronic pain management now a lot differently than I used to approach it, because I used to just be like, let's, suck it up, buttercup. But now I understand chronic pain a little bit better, mainly because of my ex-wife and a little bit because I'm finally getting into chronic pain myself. And you learn, you can teach patients that pain is in their head. You can teach them, they can learn that. And if they can learn that, they can do more. So here's the fibromyalgia kind of trigger point symptoms. So when these tender points, what a doc needs to do is the doc needs to come in and put moderate amounts of pressure on all these points. when you look at some of these points, some of you are going to go, yeah, I've got pain there. These 2 points up here are key areas of pain for most people, right? What's that area there that that pain is in? Do you know? Yeah. So that area is your suboccipital triangles. Right. In the suboccipital triangles, you have 3 little tiny muscles that form a triangle on either side of your head. Right? That area is a real common area of pain for most people. Some of you are going, oh my God, I might have fibromyalgia. Right? Those upper traps and mid traps are a common area that people get trigger points in and pain, right? Uh-oh, low back pain. I got fibromyalgia. Lateral hip pain is common. This is the weird one that a lot of fibromyalgia patients talk about that kind of sets them away from other people, because people have generalized knee pain very commonly. But a lot of fibromyalgia patients are like, it hurts right here, and they're pointing kind of like right to their VMO. And that's kind of a sign that it's maybe not just normal pain syndrome. Again, lateral aspects of the elbow. And then kind of in this area here in the neck. What's this area in the neck here? What's in that area there? So if I'm pointing in here, what are we palpating when we're kind of going down like this? You do it to kids all the time. Yeah, your lymph nodes, right? Because you got to think about it. Fibromyalgia is also autoimmune related. If you come in here and it's tender, that kind of tells you that their immune system's kind of kicked up, right? If you've got any type of rheumatoid or psoriatic arthritis, you kind of palpate in there, it may be a little bit tender. And that's just because your lymphs are kicked up. So that's kind of the trigger point syndrome there. MPS is a little different. So MPS, or myofascial pain syndrome, has to deal with the muscles interacting with the fascia around them, right? Whereas fibromyalgia is pain of musculoskeletal origin that is neurological in nature. That was a really complicated way of saying they have pain in muscles that may not be related to the pain in their muscles. That's fibromyalgia, right? So they're sore, but they have no reason to be sore. With myofascial pain syndrome, oftentimes there's a trigger event that causes those muscles to bind down, right? Inactivity can be that triggering event, right? CRPS, we talked about briefly, right? Complex regional pain syndrome. But a lot of times it has to do with trigger points. And we're going to actually palpate a lot of trigger points next semester and try to find them on everybody. All of you have trigger points somewhere. We'll find them, I promise you. If nothing else, we'll go to subscap and I'll find all kinds of plenty of trigger points on you. Because I guarantee you get in under that scapula, y'all got trigger points down there. Now, think about where that subscap is and think that it's probably not fun to palpate it. You're right, it isn't. But you'll be amazed if we do trigger point release on that subscap, how many of you guys will feel better? Because your shoulder will move a little bit better, right? Can be chronic overload of the muscle, meaning somebody's just doing too much work. It can be acute overload of the muscle, right? Just helping people move, stuff like that can trigger it. Poorly conditioned muscles, and then you try to do stuff. All of you have probably encountered somebody in your life that decides that they're going to get in shape, and they go to the gym. And that first day they go to the gym and they just tear it up. And the next day they're not back at the gym. And the next day they're not back at the gym. Because their muscles were poorly conditioned to begin with, and then they went gung-ho. And they realized that the gym's just not for them anymore because they screwed up their muscles. Postural stresses, sitting like I'm sitting right now, can cause myofascial pain syndrome. Poor body mechanics, right? That's why we talked about body mechanics with you guys in rehab, is because you guys are going to be, think about all the stuff that a PTA and a PT does that predisposes them to pain syndromes, degenerative joint diseases, degenerative disc diseases, all that fun stuff, transferring heavy patients, moving patients, lifting legs, lifting arms, all that fun stuff can trigger you into getting these MPS. And I actually know quite a few PTAs with complex regional pain syndrome. And what that is they've gotten an injury, and now that injury just doesn't go away. you know, no matter what they've done, they've got that pain in that area and it just doesn't stop. And once you get to that point, unfortunately, it's really hard to get out of it. The body just doesn't know how to do it. So we have to start with management, contributing the factors that cause the chronic overload or, you know, that are poorly conditioned. We got to get them working out, but we've got to get them at a moderate amount. Eliminating the trigger point's big, right? How do you eliminate a trigger point? Constant pressure, right? So if you literally, when we find trigger points on you guys, what we're going to do is we're going to palpate around. You'll feel the trigger point. Now, some of you will be really, it'll have a hard time finding trigger points. I'm sure Tyler can talk about this. The first time you find a trigger point, you never miss what a trigger point feels like ever again. But finding it for the first time can be really difficult. Just because everyone has a little different description of it. I like to think of trigger points when you feel palpating around the muscles as almost feeling like there's bubble wrap in the muscles. And what your goal is to pop that bubble wrap. You're going to put constant, steady pressure on it until that bubble wrap pops. Once that bubble wrap pops, that eliminates that point where that muscle is bound down, and we can now strengthen the muscle. But if it's got a trigger point, if we start strengthening it, it hurts worse. So think about it like, if this is my muscle, and it's got a normal excursion, right, that keeps it allowing move. If I have this one part that's stuck down, I now can't move the full distance that it's actually allowed to move. So I have to come in here, break up this sticky part, and get it to go back to normal length so they can actually actively do more motion. That's kind of what we're talking about when we deal with trigger points. Osteopo, right? Osteoporosis, again, we're all going to suffer from. Who's going to suffer worse from osteoporosis, women or men? Right. Why is that? That one hormone, yes, exactly. That one hormone, estrogen, right? And then also testosterone comes into play as well, just because testosterone helps with bone building and muscle building. So that comes into play as well. The number one cause of osteoporosis is menopause. Caucasian and Asian descents are the most common to get osteoporosis, and then a family history of osteoporosis. If you've got somebody in your family that has osteopo, you've got it coming. Just be ready for it. So that's primary osteoporosis. Did you guys discuss in patho what the difference between a primary condition and a secondary condition is? Okay, so what is a primary condition? That's for, okay, you're thinking of primary prevention. Oh, I just kicked over my modem. Please don't disconnect. Thank you, modem. Sorry. That you're thinking preventative measures. So there's primary conditions and secondary conditions. A primary condition would be that osteoporosis is your condition. So unfortunately, you have osteoporosis. You've developed it. That's your condition. A secondary condition is where you have some other disorder. So maybe you have rheumatoid arthritis. Because you have rheumatoid arthritis, it has caused you to have osteoporosis. That's the difference between a primary and a secondary condition. The other term that you'll hear common with secondary conditions, and I'm going to butcher the spelling, I know I am, is sequelae, right? Sequelae means in addition to. So let's talk something that maybe helps it make a little bit more sense here when we're talking about this. ALS or Lou Gehrig's disease. If you have ALS, your primary condition is ALS. Are you going to die from ALS? Is ALS going to kill you? What do you think? ALS going to kill you? No. ALS itself is not going to kill you. It is going to paralyze the muscles of respiration. So you're going to develop pneumonia, and pneumonia is going to kill you. Most people that have ALS, that have muscular dystrophy, that have a lot of even neurological conditions, they die of respiratory failure. They drown. Just like COVID, exactly, right? So if you have ALS and you die of pneumonia, pneumonia is your secondary condition, right? Same with AIDS, exactly, right? Pneumonia is your secondary condition. It is caused by you having ALS. COVID is an excellent example. COVID is your primary condition. That is a rampant viral infection of the body. You're not necessarily going to die. And this is where, if you're watching any of the news, a specific party of our government likes to use this. Well, we really don't have people dying of COVID. They're dying of pneumonia. Has anyone heard that yet? Well, our county doesn't have a lot of COVID deaths, but man, you know, right now our pneumonia deaths are out of control. Well, they've got COVID, which is their primary condition. Because they have COVID, they're developing pneumonia and dying. So this is where you can be the educated consumer and go, whoa, stop. Yes, exactly. If we stop testing, here's my theory on that, just to let you know, Renee. I've got a great theory on it. If we stop testing for pregnancy, no pregnancies would occur. Right? Same idea. Same idea with COVID. It just says, just think about that, right? But what and this was big in Florida. This is so at the beginning of this, Florida had almost no COVID cases. But in the first 3 months of the year, or actually the first about 5 months of the year, Florida had quadruple its normal of pneumonia deaths. But they didn't have any COVID, no COVID deaths. But quadruple the number of pneumonia deaths. Well, pneumonia is a secondary condition to COVID. So that's what they kind of have to, and so if you ever encounter somebody that's got this mentality that, well, no, not really, because people are dying of pneumonia, they're not dying of COVID. This is where we kind of come in and try to be semi-educational to them, but it doesn't always work. And I've started stopping disengaging with these people because facts don't matter. We're in a world where facts just don't matter anymore. We're in a post-fact world. But you try to tell them, look, the reason the person is dying from pneumonia is because COVID has infiltrated their lungs and caused their alveoli to not function as well. Right? And because those alveoli are not functioning as well, they're not pumping and opening and closing as much. So they're sending in more fluid to keep those more patent, and that fluid's collecting in the lungs, and they're drowning. Right? That's the difference between primary and secondary condition. So primary osteoporosis is you've just got osteoporosis. Women are an excellent example of it. You will develop primary osteoporosis. But let's say somebody, I don't know if anyone, I don't want to get too personal on medical conditions in here. But if somebody in here has an autoimmune disease, a lot of time they're taking glucocorticoids, steroids, in order to manage that autoimmune disease. If you're taking glucocorticoids to help manage other medical conditions, you're going to develop osteoporosis from those glucocorticoids, right? From the steroids themselves, like prednisone, stuff like that. You're going to develop osteoporosis, but that's going to be secondary osteoporosis. It's not going to be the primary cause. The primary cause may be your lupus, maybe your rheumatoid arthritis, psoriatic arthritis, any of that. And because you have that condition and you took this medication, now you have osteoporosis. So how do we prevent osteoporosis? Physical activity, weight bearing. So here's the question. Grandma says, well, I'm trying to keep my osteoporosis in check, so I'm doing chair exercises. What should you say? At that point, you need to become ludicrous. Yes, right? Become ludicrous and just start going, stand up, right? The more you weight bear, the better off you are to prevent osteoporosis, especially on your long bones, right? Because long bones are really, really important to help with osteoporosis, getting those bones, creating your marrow and creating your new bone cells, getting them up. Vitamin D. Where are we going to get vitamin D from? Where's our main sources of vitamin D? The sun, good. And where else? The thing that I absolutely, yeah, vitamins can help, good. The thing I absolutely hate drinking, milk. Right? Because most milk nowadays is infused with vitamin D. Do you ever notice that? Do you ever look at your milk label and it's like extra vitamin D or whatever, I forget what it says? Cereal, right? How many of you ever looked at your cereal box and it says enriched? Did you ever see that? Yeah, enriched means they've added vitamins to your cereal. Well, why is that? Because we realize that kids don't like eating healthy things, right? If you're a parent, you understand this. You put green stuff in front of the kids and they're like, I'm not eating it. I'm not doing it, right? You put French fries in front of them, the French fries are gone in 5 seconds. Well, at least normal kids. Maybe you don't have a normal kid, right? So the kids don't tend to eat it. So we put enhanced, enrichment in their cereal and stuff like that. Now there's all kinds of arguments out there that may not be the best idea. I'm not going to even get into that at this point. But vitamin D is important for our function. Vitamin D helps us process calcium and absorb the calcium into our bones. So we need it. That means even in our nasty, super hot area, it's good to go outside and just kind of soak up some of that sunshine, right? Make sure that you're wearing the proper sunscreen and that you're not out there for too long, but go out and get some sun every now and then, right? I'm starting to lack in it here. I'm starting to look almost translucent. And then exercise. The more you exercise, the more you're building your bones, right? So doing stuff where you're putting torque on, so even though grandma is not moving and standing, even putting torque on her muscles is causing the bones to slightly kind of twist and bend, and that's going to help build them. Not as good as walking and standing, but it's still something, right? So that's why even if a patient refuses exercises in the hospital, you should try to get them at least to do bed exercises, because something's better than nothing, right? And tell them we don't want your bones getting weak. So aerobic exercise, what's good for it is 5 or more days a week, 30 minutes of moderate or 20 minutes of vigorous exercise, right? So ideally, in order to prevent osteoporosis when you get to my age, and I still won't tell you what my age is, but old enough to know, ideally you want a minimum of 5 days a week, 30 minutes of moderate exercise, right? Moderate exercise is getting that heart rate up there, right? Resistive exercise should take place about 2 to 3 days per week and 8 to 12 reps to muscle fatigue. So we do want to work those muscles. So this is counter to a lot of people's things, right? A lot of people say, well, I don't do cardio. Or some people say, I only do cardio. I don't do any resistance. A good, healthy exercise routine kind of balances it, right? Body weight resistance is enough. You can do stuff like push-ups, pull-ups, stuff like that, and still actually get good benefit out of it. TheraBand's good too. Exercise is good, whatever you want to do it. The main thing here is we have to pay attention to patients that have osteoporosis because they can end up with vertebral body changing, meaning the actual body of the vertebra start changing their shape. It can either enlarge or it can get smaller and smaller to the point that they actually sit down and get a spinal fracture just sitting down. You'd be amazed at how many you're going to encounter in the hospital that are little old ladies and little old men that have a spinal fracture from sitting down. Just doing something as simple as sitting down, and they get a spinal fracture. Just because that osteoporosis has made those vertebral bodies so weak that they break. Avoid combining flexion and rotation. This should be everyone's kind of goal here, right? You talked about this with Dr. Sokel with lifting, right? Turning to pick something up, bad. But turning and bending to pick something up, worse. So avoiding that flexion with rotation is really important. And then you want to increase intensity progressively. You don't want to jump on the bull right off the bat. You got to give yourself a little bit of time to build. So how do we identify fractures? Well, you kind of sometimes know that you have a fracture when the bone's sticking through the skin, right? So when we're talking about fractures, they can be anywhere. They can be diaphyseal, they can be metaphyseal, epiphyseal, intra-articular. Fractures can occur anywhere there are bones, right? You can fracture your patella. You wouldn't think you could, right? Because it's a floating bone, and how am I breaking it? but you can break your patella. And it's funny, I've seen a couple of people that have had fractured patellas, and they say it's really uncomfortable. I imagine it is. You've got a floating bone now that's in pieces digging into your quad tendon. So when we talk about fractures, we have to figure out if they're a complete fracture or an incomplete fracture. Complete fracture means that bone is cleanly broken through. Incomplete, we often think of as compression fractures, where the bone's not completely snapped, but there are definitely parts of the bone that are starting to get kind of just broken apart. They can be transverse, meaning across the bone, oblique at angles. Spiral is where the bone actually kind of twists, and you get a weird type shaped fracture where the bone actually kind of bends and almost looks screw-like. Or comminuted, where two or more fragments of the bone break apart. I saw it once. Yeah, comminuted is probably the worst. I saw a humeral fracture where literally a chunk of the humerus was shifted laterally. So the upper bone of the humerus was broken, bottom bone was here, but then they had a chunk broken loose. That's called a comminuted fracture. At that point, surgery, because there's no way that's going to heal. I'll have to find that. I think I've got the x-ray of that. I've got to dig through my x-rays. So you're going to have a common terms here of undisplaced versus displaced. Undisplaced fracture means things haven't moved. Displaced means they've moved. The main thing we are worried about in PT is whether it's a stable or unstable fracture, right? You heard that when we were dealing with contraindications, right? You don't have any new unstable fractures. An unstable fracture is a fracture that has occurred that a doctor hasn't looked at that may have parts that are moving. If there are parts of that fracture that are moving, we don't want to move them. Because if we do, we can make that fracture 10 times worse. And then we can end up with stuff like a displaced fracture where maybe I've got to break through my humerus. Last night I fell in bed, and now you're coming to see me in the morning. And I say, yeah, I think I broke my arm. You're like, well, we're going to do exercise anyway, right? And now you're working with me, and here are my two parts of my humerus that are broke. And now when you work with me, all of a sudden, now the two parts go like this. That would be a displaced fracture. This would be an undisplaced, because they're still lined up and still can be healed. Then we're going to talk about relationship to the environment. Are they closed or are they opened? They used to have different terms for this. Did anyone ever remember the other terms they had for these type of fractures? Because I forget off the top of my head right now. They had another term for this, and I'm drawing a blank right now. But open or closed fractures. If the skin is open and there is bone protruding out of that skin, that's probably a good time to waive off PT. I'm just saying. Right? And it's also probably a good time to get a doc. And there are some really, you can see all kinds of really nasty open fractures if you Google it. Open fractures of the femur are probably the worst, because you've got to think about it. If that femur is poking out through the skin, think of all the muscle it destroyed going out through the skin. Right? Joe Theismann, great example of a really, nasty fracture. Caused left tackles to be one of the highest paid players in football. Complications can occur. They can end up with local or systemic inflammation, and then all kinds of problems that are related to that injury. If you have a fracture, this can totally change your life. Kevin Ware, yeah, there's another one. Good, yeah. So when you have fractures, how many of you had broken bones? It's usually about 50% of the class that have had a broken bone. Yeah, they're not fun. I can speak from experience. I've broken my neck twice now, right? When you have a fracture, especially if something to the spine, it can lead to systemic outcomes where your body just goes into this nasty inflammatory phase and your whole body starts hurting because of that one fracture. So, luckily none of mine were open fractures of the spine. That would be bad. But I did have a displaced fracture of C2 where my dens actually shifted. And they actually had to fix that. So what causes it? Sudden impact is the #1 reason of fractures, right? Can be from sports, can be something getting up and falling. It can be all kinds of reasons you get a sudden impact. Osteoporosis absolutely can lead to fractures. And as we get older, we are more predisposed to getting broken bones. It's almost like we have a timestamp on us that at some point we're going to fail. And then a history of falls. The greatest predictor of human behavior is past human behavior. So if a person has fallen before, they will fall again. It's not a matter of if, it's just a matter of when, right? I used to ride motorcycles all the time. Unfortunately, my motorcycle got stolen. A really nice motorcycle. I miss my motorcycle. But when they take you and you have the first motorcycle safety class, they tell you it's not a matter of if you get in a motorcycle accident. It's a matter of when you get in a motorcycle accident. So much so that in the hospital, we don't call them motorcycles, we call them donor cycles. Because a lot of times patients that come in from motorcycle accidents are going to end up being organ donors. So you kind of have to pay attention. You know, if you have a history of falls, you're going to fall again. Figure out why you've got that history and fix it. So how does bone heal? Well, the bone's going to go through all the normal phases, right? You're going to go through the inflammation phase where things are going to swell and it's going to protect it. They're going to start going into the reparative phase. The main thing part, the most important part of the reparative phase is hitting clinical union or radiological union, meaning that the bones themselves mate up to each other. If the bones don't mate up, you can have long-term problems with that fracture. They're going to get rigid internal fixation, so you're going to get a callus over it. If that fracture is not able to mate up, they're going to need a surgical fixation in order to keep it intact. Overall, how long does it take to heal from a broken bone? What do you think? How long do you think it takes? Yeah, that's on the minimum. I mean, minimum's 2 months, 8 to 12 weeks is common. It depends upon what bone it is, right? You break your little pinky finger, probably not as long. You break a femur, and we already know that's 10 out of 10 pain from our comedy joke, right? You break your femur, and it's not fun. It's going to be there for a while, right? And you may have to get surgical fixation for it. So understand that if a patient breaks a bone, they're not going right back to sports, right? Even if it's something as simple as a Lisfranc fracture, they're not going back to sports. It's going to take 6 to 8 weeks to get healthy again. Cancellous bone. So what is cancellous bone again? What are your two types of bone? You have cancellous and what's the other one? Spongy and hard, right? What's the other one called? So cancellous or cortical, right? Which one is cancellous? Is that our hard bone or our spongy bone? That doesn't seem to... Okay, so we've got hard, and we got spongy, right? So what I want to talk about is the bones heal differently. That's the reason why I put it here, right? So if you have that soft bone and it's leaking out, that's a problem, especially if it's on a long bone, right? They've got to fixate that long bone, the hard bone, in order to allow the inside bone to mate up and kind of goo together again. A lot of times when patients have bad fractures, they're going to put pins and rods through it. And when they do that, that can affect the overall spongy bone, and bone may no longer produce as many red blood cells as you need. So then you can end up with, surgical anemia. Epiphyseal plates. Who would get fractures of the epiphyseal plates common? Yeah, kids, right? What's the fracture that kids get that adults can't get? Green stick. Good, right? Because if you're still getting a green stick fracture at 30 years old, I want to check your license, right? So green stick fracture is kind of that splintering spiral fracture that kids will get, and it will heal normally. And that's the thing. I've seen kids that have fallen, getting broken bones, and gotten right back up and went back to play. Because that's the way kids are. We fall like that, and we're going to be on the ground crying and screaming, "Help, I've fallen, I can't get up." That's just kind of the way they are compared to us. So a lot of times during that period of initial healing, we're going to mobilize the bone. What are we going to put on a fracture that's really common? We're going to do what to that? Yeah, we're going to cast it, right? We're going to use plaster and we're going to put a cast around the bone. Why are we casting the bone or casting the limb? What is the goal? Yeah, set it and forget it. Exactly. So why we cast the bone is because we want to prevent the patient from moving it, right? I was reading last night, there was a study out of, I think it was Austria that I was reading it, that showed that patients that didn't have casts had better outcomes with fractures, as long as they could adhere to the doctor's orders. That makes sense, doesn't it? Because we know that when we immobilize the limb, we're going to cause all kinds of secondary problems with the muscles. Whereas if we don't immobilize it, as long as that fracture is set, they still are able to have some motion with that arm, which means some, like say I have a ulnar fracture. It means I still have some motion with that arm. As long as I follow the doctor's precautions, I can probably let that heal normally. And immobilization is probably the worst thing we do. Immobilization in bed, by far the worst. You guys are going to encounter that. Like some of the worst outcomes I've seen are patients that have come in with really bad car accidents, where they've got an arm broken, a shoulder broken, a hip broken, and a knee broken or something. And they're in those like full body cast in traction, right? And the reason we got them in traction is so they don't, tighten up. But then the day that they're able to get up, everything's wasted away. I'll speak from experience. When I first broke my neck back when I was 18, I had a C2 fracture, right? C2 fracture of the dens. And I had a halo. Has anyone ever seen a halo before? I think I've talked about them briefly. Halos where they screw metal plates into your head. Loads of fun. I had this big vest that came down to here, and there were poles that came down from my head and anchored my head like this. Yes, exactly. So now I was in that for about 6 months. And then they pulled the screws out, which, let me tell you, wasn't fun. And as soon as they took the halo off, what do you think happened to my neck? Yeah. I was like this. And it was a struggle to pull back to neutral because all of those muscles, thank God it didn't break again. Could have. But it literally, I remember them taking the poles off, because that was they pulled those out first, and I'm sitting there like this while they're trying to unscrew it. I'm like, help me. Right? Just because my muscles are so weak. That immobilization is horrible, but sometimes it's needed because, in my case, if that den shifted even another 2 or 3 millimeters, it would have shifted into the spinal column and I'd be paralyzed. I'll take the mobilization and going through physical therapy in order to not die and not be paralyzed. Just saying. We're going to have to do functional adaptions, right? So what happens if I break my right arm and I'm right-handed? Overall, I'm going to have to readapt to using my left hand. In my case, I'm left-handed and my left hand doesn't work anymore, so I've had to learn to become right-handed. Right? All that comes into play. If we break a leg, we may not be able to go up and down stairs. All those are going to be functional adaptions we're going to have to make when we get fractures. Post-mobilization, we're going to start mobilizing those joints. Very, very low-grade mobilizations to start, and then getting higher and higher as we get further along in the actual healing process. Pnf stretching we're going to talk about. I think next class I'm talking about Pnf. Pnf stretching has been shown that in a post-operative, post-immobilization fracture to show really good results with stretching the muscle, because we're going to start using our neurological systems to stretch the muscles. We're going to get back to functional activities, some muscle performance, and the main thing here is scar tissue mobilization. With a bone fracture, the number one way we're going to mobilize that scar or the callus of the bone is by using that bone again. So that means if I've got to fracture the arm, I got to get some weight bearing going on. I got to get some push off, right? I've got to work on doing a little bit of pushing up and getting that bone moving. because that callus that forms over the bone can actually cause all kinds of other problems. If I've got a lump now in my radius, right, because I've got a fracture, well, there's all kinds of muscles that are passing over that radius, and I've got that muscle, and now I've created a little bit of a tendon point or tension point that can affect all the poles of my extensors and my flexors, depending upon what side it's on. So we need to mobilize that scar tissue. All right, so we're going to talk about surgical interventions next. Let's take a 10-minute break. Let me pause the recording. So we're going to talk about surgical intervention post-op management here as a little bit, right? So anytime that we're talking about surgical interventions, we're actually going to be cutting into a person, right? So you have to understand that. And when we're doing that, we only want to cut into them if we absolutely positively have to, because they're going to be incapacitated, and overall it's going to change their overall function. So docs really have been getting a little bit better about it, and this because insurance companies are pushing them for it, is not forcing a patient directly into surgery. So anytime we should do a surgical intervention is where patients have incapacitating pain at rest or with activity, marked limitation in motion, gross instability of the joint or bony segment, severe joint deformity or abnormal alignment, significant structural degeneration, chronic swelling, failed previous surgical or non-surgical management. So maybe we had a previous fixation of a bone and that failed, or any significant loss of function. So just because you have a degenerative knee is not enough to require a knee surgery. You really have to have one of these before you're getting the point of surgery. And most here in America, I'll say, is a lot of people will go into the docs expecting to want to go right into surgery for knee problems. And the docs sometimes have to slow them down and say, hey, look, you know, you don't definitely need surgery. You need some conventional therapy. And then they're going to come see us and be like, well, the doc said I had to come to physical therapy, but I know it's not going to work. And it's amazing how many times it actually works. So when we're talking about pre-op, that's the major thing. And a lot of insurance companies are getting better at this, where they're sending the patients to pre-op physical therapy. There have been study after study after study that have shown a patient that sees physical therapy right after surgery and then long-term after surgery have better outcomes than people that don't have pre-op PT. Well, why is that? Well, because we can educate them on what to expect, right? A surgeon's going to come in, and what's a surgeon's job to tell you about with the surgery? What do they have to tell you about? Does anyone have, yeah, the implications, right? The implications and contraindications. Just to let you know, we're going to put you under general anesthesia. And, you know, there is that chance you could die from it, but it's a small chance, right? They'll tell you just kind of what's going to happen. They don't tell you what to expect per se. And that's kind of where we come in. We can talk to them about what it looks like pain-wise from that surgery. We can assess their existing range of motion and joint integrity so we know what we're going to face coming out of that surgery. What's your skin look like, right? A patient that has very non-patent skin, meaning somebody that's got really kind of brittle skin, is opt for infection right after surgery just because that skin's not going to heal as well. What does their muscle performance look like? What does their posture look like? We can assess their gait. We can assess their functional status. That way we know a pre-op picture so we can get them to a post-op picture. A lot of times with pre-op physical therapy, the other thing we can do is we can set them exercises, right? And give them this kind of plan of care that lets them know what's coming up. We used to have pre-op, back when I was at Pennsylvania, we had our joint replacement program. Every patient had to come into 3 pre-op joint replacement physical therapy classes. And what those classes came into is they had to see OT one day to talk about how they're going to get around their house after their surgery. They saw PT another day. And our job was to teach them how to use assistive devices before they got the assistive device. You'll be amazed if you have a family member that is going to go in for like total joint replacement, have them walk around the grocery store with a cart. Because the grocery store with a cart is very similar to what's going to feel like walking around with a rolling walker. And they're going to get a rolling walker if they have a total knee, a total hip, something like that. Talk about the overview plan of care. Post-op precautions, we're going to talk about how they get in and out of bed. They also have to see respiratory to talk about, doing the breathing exercises after surgery, how they're going to walk, and most importantly, wound care, right? This is an area that, I hate to say it, surgeons are a little lax in. Most surgeons and even nurses, they'll say, change your dressing twice a day. Did anyone ever have surgery and they told you that? Go ahead and change your dressing twice a day. I know I had this when I had my neck. And I'm assuming they did it because I knew what I was doing. But post-op, when I was getting ready to be discharged, the only thing they did was, here's a pile of supplies. Make sure you change your dressing twice a day. And change yours for 5 days, right? But here's the deal. Did they show you how to change the dressing, Dylan? Yeah, exactly, right? All they tell you is change it. And you're like, okay, is it like a Band-Aid, right? And most patients don't have that intrinsic knowledge on how to change a bandage. Well, we can come in pre-op and go, okay, that was good. I almost knocked off my coffee cup. We're going to do a lateral compartment release of your elbow. So you're going to have a long set of stitches going down that lateral aspect of the elbow. You're going to have a long ABD pad, which is that big, thick pad going down that aspect. So we're going to put one on you. You want to apply your tape here and here to keep that ABD pad attached to the actual wound so the drainage will go into it. Right, exactly. It's really important to train these patients. So even if I know I'm not doing wound care on this patient in the hospital, I still educate them on dressing changes because they're not going to learn it. And we are going to have a whole comp on dressing changes. So huzzah! So you guys will learn how to change dressing, how to pack wounds. And what you should do then is when you see your patients, you should teach them. A lot of times when I'm doing wound care, if the patient can watch me do the wound care, I'm going to have them watch me if they can tolerate it. Some patients can't tolerate it, or if they have a wound back on the urceal tuberosity, it's kind of hard to watch somebody change dressing back there, right? But most patients aren't instructed on how to change it. They're just told to change it. And then once they kind of have it, we're going to look at post-op, right? We're going to have to do a post-op examination evaluation. So you're going to have, commonly when you're in the hospital, you're going to have patients that are in pods. Does anyone know what pod stands for? Some of you that are in the hospital may have encountered this. I don't know, Michelle, if they call it in your hospital or not this, but usually they'll call them pods. Yes, pod people, exactly. Post-op day. And then there'll be a number behind it. So some people will be pod zeros, some will be pod ones, some will be pod two, some will be pod threes. Hopefully you don't have any pod fours and fives because they should be out by then. Ideally, and you're going to find most hospitals have found out that 2.5 days is the maximum time they can keep a patient in the hospital and make the most off of them. So what you'll find is like a total knee replacement will get therapy 2 times a day up to pod 3. And on pod 3, they get it once and they're kicked out. Because after you get to that half day on pod 3, the hospital starts losing money. And they don't like to lose money. They want people in and out as soon as possible, right? Back when I started, man, people were in for total knee replacements. They were in for a week or 2 weeks. We had great times with them and great ability to work with them. Now, not so much, right? So ideally, a PT should really see a patient pod 0. As soon as they're able to come up from this other term, what's PACU? Did you guys learn this in rehab yet? That's PACU, but close enough, Justin. So first of all, what's the CU stand for? CU is common for almost all of these things. ICU is what? What's ICU stand for in the hospital? Intensive care unit, right? So we know that CU is care unit. PACU, right, is post-anesthesia care unit. If any of you have had surgeries, you've woken up in the PACU, right? It's kind of what a lot of times they'll call it the holding tank, because that's where people come right after surgery to bring them out of their anesthesia. And why they have to have that is because a lot of people don't react really well to anesthesia. And the big one is, when are you allowed, when's the last time you're allowed to eat before surgery? Does anyone know what the usual is? Yeah, 24 hours, or the main thing they'll say is NPO after midnight. So you've become a gremlin, right? What's NPO stand for? Nothing by mouth, right? Nothing partaken orally. So that includes drink, that includes food. Some doctors will allow you to chew on ice chips. Thank you, that really solves my hunger problem, right? But about 40% of the patients don't listen to that. And the reason you're told that is because a lot of times when you come out of anesthesia, you're nauseated. And if you're still out of it, you can aspirate because you're going to vomit it up and you're not completely out of your anesthesia and you'll inhale it. So if nothing else, don't eat after midnight on the surgery night, please. Right? So a patient comes up from PACU, they're recovered from anesthesia. That starts pod 0, post-op day 0. That's the day of surgery. PT should really see them and evaluate them that day because that's the worst the patient's ever going to be. Hopefully, right? That tells us where they are at baseline. And then we can begin pod 1, pod 2, pod 3, right? And we're going to move through all those normal phases, right? We're going to move through the maximum protection phase at the beginning where we're just doing kind of passive range of motion, move into a moderate protection phase where we start doing some active assist, and then get to the minimum protection and return to function where we start getting the do stuff. Do I have a question or is that just a click? No, it's just a click. Most surgeons have a protocol for all their surgeries. This is where it gets really important. You have to be a really, really, really smart PTA. Because in a hospital, on average, you'll have 5 to 7 orthopedic surgeons. And you have to know all of their post-op protocols. Don't tell me my fire alarm's going dead. So you have to understand and know that what this patient's post-op protocol is, what that patient's post-op protocol is, because they may be very different. In the hospitals I've worked at, we've standardized the protocols for the doctors, meaning that every doctor uses the same protocol because it makes it easier. But a lot of docs don't like that. They want their own spin on the protocols. Okay. It wasn't my alarm. Good. Somebody else's alarm. I feel better now. So post-op rehabilitation. Let's go through. We got a few minutes here before I have to go into kines. Patient comes into your hospital. I need a blank sheet. New share. Let's get a whiteboard here. All right. So I've got a whiteboard here. Can you guys see the whiteboard? Yes? Okay, good. So patient comes into your hospital. We're at post-op day 3. At post-op day 3, usually we have to discharge them. I actually want to move that, clear that. So I want it more in the middle here. And you guys are going to become part of this discharge planning for your patient. So at post-op day 3, we have a couple places we can send the patients. Goodbye. I'm drawing a bunch of arrows here. All right, so where is the number one places, or very white. What is the number one place patients want to go after surgery? Good, home, right? Home is ideal. That is perfect. If they're not quite good enough for home, yet they still need a little bit to get better, what's the next place we can send them? Good. IPRH, inpatient rehab. Now, they're not good enough for rehab because they can't tolerate rehab. What's the next place we're going to send them? Okay, right? SNF. We're really trying to get out of using SNF so much because people hear nursing home and they think, so a lot of them are rebranding themselves to TCUs. Does anyone know what a TCU is? Transitional or temporary care unit, exactly. It's still a nursing home. They're just trying to get out of that nursing home. Now the patient's really bad, can't go to the SNF because they still require care, and they're kind of a real high-level care. What's the last one they can go to? It's called an LTAC. Have you guys heard of LTACs? We'll talk about assisted living in a bit. Yeah, long-term acute care, right? So that's a hospital for patients that really are not good enough to go out into the community, right? Even a SNF or a TCU is out into the community. So these are kind of the ways that we can go along with the patient. That's the first kind of idea. Now, we can send them to assisted living facility. That's kind of an offshoot. Like if I draw, that would be kind of a split between home and a nursing home would be an ALF, assisted living facility. A lot of people don't go there, so I'm not really worried too much about it. Assisted living facility is more of a freestanding facility where freestanding home where they get a little bit more care. So now when this patient goes home, let's go to that patient first. When they go home, they can go 3 different ways. Well, actually, technically 4. I'll add a 4th one because 4th one we don't ever count. They can go home with no PT. Yeah, ALFs can be. So going home with no PT means patients perfect. That'll never happen. The next thing that could happen is they can go home with home health PT. These are kind of the options we have for sending patients home. And I'll talk about kind of each of them briefly here. So we can send them home with no PT. Not ideal. But you may have somebody that's a rock star that doesn't need PT. You know, it happens. I've had maybe one in my entire career where the patient just is literally that rock star. They come out of total knee replacement, man, they've got 125 degrees of knee flexion. Manual muscle grades are all 5 out of 5. They don't need PT, send them home. Now, patient that goes home that can't commute by themselves or have no access to transportation, they need home health PT. Home health PT is where we're going to come to their home and do therapy for a while. The goal of home health PT should be to get them, so we're going to go from home health. The goal should either to go here or go down here, depending. The other option we can have is outpatient rehabilitation. So I'm going to talk both about the inpatient and outpatient rehabilitation because they have a specific requirement. In order to be classified as an official rehabilitation facility by Medicare rules, you have to provide the patient with 3 hours of therapy per day. So I'm going to put this behind my inpatient rehab here. Oh, that's an arrow. That was not what I wanted. Oh, no. All right, I'll just put IPRH again. Yeah, we're going to talk more about hours. So when you talk minutes, now you're more talking sniff, honestly. But in an inpatient facility, they have to have 3 hours of therapy a day, and they have to have a minimum of 2 disciplines. So what are the disciplines they could get? So PT is obviously one of them. What other disciplines can they get? OT speech, and one more. RT, good, respiratory therapy, good. So they have to have 2 of those. Now, they could have all 4 and just be getting 3 hours split amongst all 4 of those disciplines. They could have 3. They can't have 1. They have to require 2. But whether they're doing outpatient rehab up here, right, or whether they're doing inpatient rehab down here, they have to tolerate 3 hours of therapy. The difference is inpatient rehab, they're in the hospital, they're constantly in the hospital manages their meds, hospital manages their care. At outpatient rehab, they go home after their 3 hours of therapy. So they come in for their 3 hours of therapy, and at the end of their 3 hours of therapy, they go home. That's kind of an ideal situation, isn't it, for patients? Because they get the best of both worlds then. They get that intensive 3 hours, but they also get to go home at night. And then we have our traditional outpatient PT. Home health, getting out of the hospital, whatever, they really should be getting outpatient PT just to get themselves back to function, right? So that's kind of the home route. Home splits like that. This is a really complicated drawing. If they don't go home, the next place they can go is inpatient rehab, which I just talked about. They have to have minimum of 2 disciplines, 3 hours a day. If they don't get that, Medicare will not qualify them for inpatient rehab. They're also going to have a very special set of tests run on them called a FIM, but we'll get into that later. But the FIM is basically an independent measure scale to indicate they need inpatient rehab. Now, if they can't tolerate 3 hours of therapy a day and they can't go home, the next best thing is a SNF or a TCU. And I'm going to put best thing in quotes. Are you guys using the IPRH or the IP? I forget what that's called now. Oh my God. Use the GG score? Okay. Well, still, here's the deal: is you may use that, but in the back end, I'm going to tell you that for Medicare, they're still converting it to a FIM because Medicare is not giving up the FIM. It's silly. Medicare will not give up. Medicaid does not give up the FIM. So the good news is the GG works, but I'm betting in the back end it converts it to a FIM on the software because most stuff covers the FIM. I prefer the SF36, which we'll talk about next semester, and the SF36 translates to a FIM really easy as well. They're just testing. That's all they are, guys. Don't forget about those yet. It's a lot of letters. So again, they can't tolerate 3 hours. They can go to a SNF. Now, at a SNF, they may get as low as 30 minutes of therapy a day or 30 minutes of therapy every other day, right? They're not going to tolerate therapy very well. They're not going to get better fast, right? So from the SNF, the interesting thing is they can go from a SNF to the inpatient rehab facility, or they can go to the SNF and end up going home. Or worse, what no one ever tells you about here is all of these can lead you going back to the hospital if you don't follow the procedures, right? So from the SNF, our goal should either be to get them back home, which very rarely happens, or get them to a rehab facility where they can get that 3 hours so they can get ready to go home. And then we have this kind of outlier down here called the LTAC. When you see the LTAC, a lot of times what you're going to think is patient's not ever going to get better. LTAC service a lot of comatose patients, patients that are on long-term wound care, med care, stuff like that, where they're rarely going to get physical therapy. And most LTACs, they might get therapy every other day to every 3 days. So obviously, we've learned the more therapy they get, whether it's PT, OT, speech, respiratory, the more likely they are to go home. This is a really convoluted plan. And here's the deal. As a PTA and as a PT combined team, when do you think you've got to start planning to send a patient home? Where to send a patient? When do you think you got to start thinking about that? Yeah, the day of admission. As soon as, and for the PT and PTA, the day of the eval, we have to start having an idea where this patient's going. Because who are the people that are going to decide where they go? What are those special people in the hospital called? Social workers, right? And now the new term is case management, right? They're really trying to get away from social workers because they say that they, here's the reason why. Technically, in order to be a social worker, you have to have a degree in psychology or sociology, which most of them don't. It's funny, you'll find that most case management are 18, 19, 20-year-old kids. I hate to say it. And they're overwhelmed. God, I love good case managers, but there are far too many bad case managers. I worked in an inpatient rehab facility. I won't name what they are, but one of them, the largest ones in the country that handles inpatient rehab facilities. And our case managers, our incoming case managers, would take comatose patients to inpatient rehab. Think about that for a second. A comatose patient to an inpatient rehab facility where they have to get 3 hours of therapy a day. Do you see a problem with that? Well, why are they doing that? They're trying to fulfill census. Does this kind of screwed up drawing that I just drew make sense? I wasn't sure if Dr. Sokel was going to cover this, and I wanted to make sure I covered it, because this is important. So if you guys are going to a hospital for your acute care affiliation, understand that literally as soon as you see that patient, you've got to be thinking in your head, where are they safe to go to? If they're fumbling, stumbling, and bumbling all over the place, they can't go home. They can't. And the number one thing, I will use this against, I'll say against patients, not a good term, but I will use this against patient when they say, I don't want PT. Do you want to get out of the hospital? Absolutely, I need to get out of here. I'm your way for getting out of here. Because I have to report your progress to the docs, to the nurses, to the case management in order to tell them where you're going. If you don't do PT, you're going to a SNF, honestly. They will. They'll send them right off to a SNF and not think twice about it on post-op day 3. And the SNFs are glad to take them because that's money. Right? And some of the SNFs in our area, and again, I won't mention any names, are really horrible to patients. I ran into a SNF where I've had to report them because I saw a patient that was laying in his own urine for 3 days. And why was he laying in his urine for the 3 days? Because he made the nurse mad. Don't make Ate mad. That's all I'm saying. Some of you get that, some of you don't. All right, I want to go back to my PowerPoint now. I wonder if I can screenshot this. I'm going to screenshot this so I can maybe make a picture for you guys then. Hold on a second. Snippet. There we go. All right, I got a screenshot of it. They're always bringing good food. Okay, at least Kaylee understands what I'm talking about. For Ate. Don't make Ate mad. I've learned all about Ate. All right. So that's kind of putting that rehabilitative focus, post-op rehabilitation into kind of focus. We actually have to know where the patients are going. What can limit them from going places? Pulmonary complications. They need to be doing their breathing exercises. They need to be using their inspirometer. What's an inspirometer? It's the thing that's sitting over on the heater that they never use. It's that little breathing device they're supposed to practice breathing with. They get a DVT that can limit them going places. Subluxation, restricted joint motion, or a failure or loosening of the components can all limit them from going places. We already talked about Homan signs a little bit. Risk factors for DVT, immobility is the #1 risk factor, which is post-op care. The problem with DVTs is they can lead to pulmonary emboli. That's where that DVT breaks loose and goes to the lungs. Shortness of breath, cyanosis, all of those are signs that they've got a pulmonary embolus. If you ever encounter somebody that's having shortness of breath and their lips are turning blue after surgery, get the nurse and call a code. That means they've probably thrown a blood clot and their lungs are no longer processing air. Bad things can happen. What can we do to reduce the risk of vein thrombosis? TET hose, ankle pumps, and getting them out of bed. If they've had a DVT, they're going to be on prophylactic medications for it. A lot of times there's all kinds of them out there, heparin, warfarin, all of those standard. There's the P one I can't think of right now. If they're on medications for DVTs, we just have to be aware to manage and make sure that we know the signs. If they start stand up every 3 to 4 hours is ideal, right? Or at least get seated. Get them out of bed. Beds are killers. And then after they get out of the hospital, they need to maintain their post-op care for DVTs, meaning they need to keep taking their meds until the docs tell them to stop taking it. Here's kind of the common areas that we're going to get those DVTs. A lot of times they're going to happen back here in the posterior aspect, back in the great saphenous, right? They can happen here in the popliteal as well. So all of that can lead to patients getting blood clots. And if you look how big these blood vessels are, that tiny blood clot can break really quickly loose and travel rapidly back to the heart. And the heart will pump that right into the lungs. So this is a really long kind of write-up here about what open surgical procedures are. You need to understand what the difference between an ORIF and an OREF is. Anytime that you have a fracture or a hip replacement or a knee replacement, you are doing an open reduction. Open meaning you're opening the skin up. Reduction meaning you're bringing the bones together. Does that make sense? So almost every surgery that you have on bones is an open reduction because you can't do surgery without opening the patient up. The difference comes whether it's an internal fixation or external fixation. So IF, internal fixation, EF, external fixation. How do you know if a patient has an OREF? Yeah, there are pins and rods outside the body. Exactly, right? So pins and rods outside the body, that's an external fixator. Now, can you grab a hold of that and use that to move the limb? Say if I got a big rod on the outside of my arm, just grab a hold of that and pull me around with it, right? I would not suggest it. Now, the interesting part is, it actually is sturdy enough to do that. But just don't. It's not comfortable for the patient. I mean, I've had to lift legs with their external fixator just because that was all I had at that point. It was either that or the patient was falling, right? And it doesn't really hurt them. It's just really uncomfortable. Don't use the external fixators like the one I had, the Halo. Don't use that to move me around, right? So open reduction is necessary for surgeries because we have to open the limbs up. So the difference is internal or external fixation. Arthroscopic procedures. Arthroscopic procedures means they are getting into the joint with a scope or a camera. Probably a few of you have had arthroscopic procedures. If you had arthroscopic knee surgery or arthroscopic shoulder surgery, it's where a lot of times you have those 3 holes, right? 2 of the holes are to send the tools in. 1 of the holes is to send a camera in. And they're able to do microsurgery in there without having to open you fully up. Obviously, arthroscopic is better than open reduction because if they can do arthroscopic, it's less invasive. You can do meniscal repair where they cut out part of the meniscus, ACL repair where they're going to fix the ACL, or chondroplasty, where they're going to add extra cartilage to the end of bones to provide cushioning, where they're going to donate it from somewhere else. Again, long read here for you guys. I just put it in there so it explains them, but that's the main thing with arthroscopic. It is less invasive than ORs, right? Operating room surgeries. And a lot of times this is the new way of doing surgeries. I mean, we're even looking at this point of doing some heart surgeries arthroscopically, right? If you've seen the Da Vinci robot and stuff like that, they're able to do almost open heart surgeries with an incision about that big, which is amazing to me. Arthroscope assisted procedures are where we may do an open reduction surgery, but we're also going to send a scope in to make sure that things are functional. They're also called mini open procedures. So, there's a picture of I couldn't find his picture of the leg beforehand. There's a picture of my buddy's leg before they did all the pins and rods. I didn't know I put this into this lecture. Can you see the problem right there? Lots of breakups. And then there's pictures afterwards. There's what his leg looked like for about 9 months. Tissue grafts. We already talked about these. Allograft is your own tissue. Allograft comes from a source other than you, usually a cadaver. Xeno is from one species to another. And then synthetics are the new ones. Synthetics are grafts that are synthetically created, usually by Gore-Tex or Dacron, which are synthetic materials that have an alternative to knee tissue. I'm guessing in the near future, we're going to be 3D printing meniscus and 3D printing ACLs. I really believe that really close in the near future. We may be 3D printing hearts soon, right? Where we can take a piece of the person's DNA and 3D print a heart that matches their DNA. To me, that's amazing. I don't know about you guys, but the day that comes, it's going to be so amazing. The downside right now is synthetic grafts and that, high rate of failure. They're not as good as regular grafts. We can do muscle repair, tendon repair, ligament repair, capsule stabilization, where they do a capsulopathy, where they shift the capsule. They can reduce the labral, where they do a capsule labral reconstruction. They can burn off stuff. Anytime you hear ablation means things are getting burnt. No, it won't be invented in America. It'll be Sweden or Norway, watch. Tendon transfers are common when we have patients that have issues with their tendons or realignment surgeries. If you've ever ripped a quad tendon, you're going to have a tendon transfer. Release of opening of tissue. You can have a myotomy, where they're going to cut parts of the muscle out. Whenever you see a tomy, they're cutting. Right? So a myotomy, they're cutting out muscle. Tenotomy, they're cutting out tendon. And a fasciotomy, it's spelled wrong. Fasciotomy, good job, book. It's fasciotomy, they're cutting out the fascia. A lot of times they're going to do this to make space for swelling. Anytime we have decompression, the main thing with post-op management is going to be managing the swelling afterwards, meaning we're going to do compression, rest, ice, and elevation. Arthroscopic debridement, we already talked about, where they go in and clean stuff out. Synovectomies are where we're going to go in and actually cut out some of the synovial joint where it meets up with the actual tendons. And this is, again, to provide space. You can have synovectomies of the hand in order to open up space in that carpal tunnel. Articular cartilage. A lot of people tear their meniscus, so they're going to go in and do abrasion arthroplasties, drilling, and microfracture repair, where they'll go in and cut out and refix the areas that actually had that problem. Chondrocyte transplantation. They'll borrow cartilage from other areas, specifically usually the glute area, and replace it into areas like the knee, where you may need some extra cartilage. That's Boston talking. What the hell? The cartilage. Autografts, where we borrow stuff from ourselves. You can also borrow it from cadavers. I've seen people where they've taken out meniscus from cadavers and put them in new people. It's kind of creepy to me, but it does happen. Arthroplasties, where we replace a joint. They can either excise the arthroplasty, excise it with an implant, interpositional arthroplasty, or just a total joint replacement. The main thing you're going to see with arthroplasties are total joint replacements of either the hip, the knee, the shoulder. We don't have total hip wrist replacements yet or total ankle replacements yet. but they're coming. There is a synthetic ankle now. So we'll see what happens with that. Arthrodesis, if you see that, it's a fusion. I have an arthrodesis of my neck. My joints are now fused. The most common area you'll see arthrodesis are the ankles. And we talked about the open-reduction internal fixation. Understand when it says internal fixation, that means there are rods and pins inside. You have to be paying attention to that. We're going to talk more about these osteotomies in 5th semester when we talk about cutting off bones and doing transplants. So don't totally freak out about that right now. All right, so that should be the end of this one. Yes, I know I stopped share. So let's take another 10-minute break real quick, and then we'll get into kines. Does that sound like a plan? How are you feeling? Do you want 10 minutes? Okay, so take from recording here. So we are back to recording now. And so now we're moving on to kines. I'm going to start talking about the shoulder girdle itself. And when we're talking about the shoulder girdle, understand the shoulder joint itself is the glenohumeral joint. So that's where the glenoid fossa interacts with the humerus. The shoulder girdle is everything outside of that. And that allows for the glenohumeral joint to have normal motion. So kind of looking at that here, right? So we've got a couple parts that make up that glenohumeral joint. We have our AC joint, right? So I'm going to take my ice pack off my shoulder here. We have our AC joint out here. We have our SC joint, our sternoclavicular joint, right? And then we have our glenohumeral joint, which is what we'll talk about when we talk about the true shoulder joint. But we also forget about this. We have a scapulothoracic articulation, where the scapula will move on the ribs. So that's all part of the shoulder girdle. Some of the bony landmarks that are important for you to know. Well, we obviously have to know the scapula. The scapula runs from about rib 2 to about rib 7. So it's a good kind of estimate that if you can find the inferior angle of the scapula, you can find rib 7. Same thing if you can find that superior angle, a lot of times you're at about rib 2. So here's that scapula, all these bony landmarks. The scapula has a ton of processes and stuff like that because a lot of muscles attach to this, right? We have our superior angle. We have our inferior angle. We have our vertebral border, which is the part of the scapula that runs along the spine. We have our axillary border or armpit border. We have the spine itself, which is on the back side of the scapula. We have the coracoid process, the acromion process, and the glenoid fossa. All of those you have to be able to palpate and find, which is why anatomy was so important. The main reason for that is all of these are going to be muscles we're going to work with. We need to know what muscles fall in, attached to the superior angle, the coracoid process, stuff like that. Here's our clavicle, again, the most fractured bone in the human body. There are 2 ends to it. They're the sternal and acromion end. Good news is they're named for what they attach to, right? Sternal end goes to the sternum, acromial end goes to the acromion. I often remember when I'm looking at this, if I'm looking for the hook in my cane or the handle of my cane, when I look at this, the handle of my cane is my acromial end. And then you have the body part of the actual clavicle that kind of allows you to have that strength and the length of the body itself. Here's our sternum, right? You wouldn't think that the sternum has anything at all to do with that, the shoulder girdle, but it does because the clavicle attaches and moves with it. You have your manubrium, which is the shield portion of the sternum. You have the body, which is the long part, and then we have the ever-present xiphoid process, which is the tip. And that's what we kind of try to avoid when we're doing any type of chest compressions, because if you push that xiphoid process, it can go either into the lungs or back into the spleen. And either way, bad things will happen if you force that point into those. So at the sternoclavicular joint, so go ahead, and what I want you to do is I want you to find your main part of your manubrium, come out, and find where you have that gap. So you have a gap where your fingers kind of sink in. That's your sternoclavicular joint. A lot of times in most people, that's very sensitive. Like, to me, it's really kind of not comfortable to touch, right? On there, we're going to have a couple ligaments. We have the interclavicular ligament, which goes between the clavicles. We have the sternoclavicular ligament and the costoclavicular ligament. Good news is, if you ever have a question on your boards asking about having a tear in one of these ligaments, the ligaments are named for where they attach, right? So if you have a tear in the costoclavicular ligament, that clavicle is now free and moving and not attached to the ribs. If you have a tear in the interclavicular, that means the two clavicles are no longer connected to each other. Same thing if you have the sternoclavicular. Then we go out, follow that clavicle all the way out until we can find that next hole that drops in. Out there, we've got the acromioclavicular space. And in that area, there are a mess of ligaments, right? So you have the AC ligament, which is a common ligament that gets kind of overstretched. You have the coracoacromial ligament. You have the trapezoidal portion. You have the conoid portion of the costoclavicular ligament. All of that comes into play. The main goal of that, all those ligaments, is to hold that clavicle in place, because when you look at the clavicle itself, it's kind of a free-floating bone as part of the thorax. It's not as attached as most of the other bones. It's only attached via ligaments. Here's looking kind of the latter aspect. So the coracoacromial ligament is going to form that roof over the shoulder joint. And the other thing that's going to allow is it's going to allow supraspinatus to kind of pass down as well. So a lot of times when you get a problem with the AC joint, what's going to happen is you're going to have supraspinatus impingement because everything's kind of closing off and pinching down on that big muscle tendon. But it forms the roof, so it protects that glenoid fossa. So motions of the scapula. We have elevation and depression, right? So the scapula can elevate, it can depress. It can protract, it can retract. It can rotate up, it can rotate down. And then there is slight back where it can tilt and lift off the ribs. So here's elevation and depression. Elevation and depression comes along when we're shrugging. Right now there is some upward rotation with shrugs, but for the most part, shrugging up and down is elevation and depression. So we can force it into elevation, force it into depression. Upward downward rotation occurs when we're moving the shoulder, right? So in order for me to move my shoulder, if here's my scapula, it has to rotate upward and allow me to get this full range of motion. Again, you have a little bit of tilt where they kind of tilt like this. You also have tilt that goes up and down as well, so it rotates away from the body. The main idea here you have to understand is this scapulohumeral rhythm. Finally, which name makes sense? Oh, names that make sense. Okay, gotcha. Didn't catch it when you typed it. Now it makes sense to me. My brain is a little slow today. Did Dr. Johnson talk to you guys about scapulohumeral rhythm yet? Or just briefly mention it at least? Okay. So scapulohumeral rhythm talks about the motion of the shoulder joint versus the motion of the shoulder girdle. So when you are lifting up and going into shoulder flexion, the first 30 degrees of shoulder flexion and shoulder abduction is pure shoulder movement. That means it's pure glenohumeral movement. It's just here, right? And you can do that because if you come up here and lock down your scapula, you still can get about 30 degrees of motion, but you can't get past that if you lock down your scapula. It kind of locks in, and it can actually get painful down at the inferior angle of the scapula if you push too hard. From then on, there is a 2-to-1 ratio. So for every 2 degrees the shoulder moves, the scapula moves an additional degree. So how much shoulder flexion do I have? What's my normal range of motion for shoulder flexion? 180 degrees, right? So if we subtract off that first 30 degrees, That means we have 150 degrees of motion that has to accompany with scapular motion. So 150 degrees, so here's 30. From here on, the scapula has to move in order to allow me to get there for that last 150 degrees. That means overall, your scapula has about 75 degrees of rotation and upward rotation with movement. So for every degree above, or every 2 degrees above 30 I go, the scapula is going to move 1 degree. So 2 degrees more, 1 degree more, 2 degrees more, 1 degree more, 2 degrees more, 1 degree more. That's really important to understand because, again, just take one of your hands, I don't care which one, get back and lock in on your scapular spine with your fingers and lock it down. Don't let that upwardly rotate. Now lift your shoulder into flexion. I'm trying as literal hard as I can, and I can't get anywhere. You can see the muscles kind of quivering, right? I can't get anywhere because my scapula is locked. Now, as soon as I let go and allow my scapula to move, I can move. So every 2 degrees above 30, I move. My scapula is going to rotate 1 degree. Same thing in reverse. For every 2 degrees I come down, scapula is coming back down by 1 degree. Does that make sense for that scapulohumeral rhythm? Because that's an important concept that's going to come into play when we talk about pathologies. Okay, good. Thank you, Emily. Now, let's think about something. Let's say I have an adhesion down here on my inferior angle of the scapula. Now you've got a patient coming in and going, I can get here, but I can't move. It won't let me move past here. That could be causes of frozen shoulder, right? Scapulohumeral rhythm is really important for motion of the shoulder. It can lead to frozen shoulder. So what we're going to do is we're going to come back here. I'm going to get a hold of the spine and out here at the coracoid. And I'm going to get a hold of down here at the inferior angle, and I'm going to mobilize that scapula for the patient. We will talk more about frozen shoulder, absolutely. That's coming up in pathologies here. Or, as Dr. Vreskin will tell you, adhesive capsulitis. We're not allowed to use the FS term, frozen shoulders. So scapular winging. This is a problem when a person has a very specific muscular imbalance. This is where that inferior angle of the scapula kind of wings up and gives them wings on their back. I have to find the picture from the quarterback I treated from Pennsylvania. I've never seen anybody with this bad a scapular winging, but his scapula would come out 90 degrees. Erica hates it. Also, when I find his photo, you'll really hate it. Like, he looks like he's got platforms on the back of his back when he's pointing out like this. What muscle will keep scapular winging from happening? Serratus, good. That's good. You guys got that. Serratus anterior is the main one, right? So that's why we're going to work on what we call push-up pluses, where you're going past that normal kind of push-up area. That's okay, Emily. We understand. So muscles of the shoulder girdle. Well, we have the traps, right? Traps include upper, middle, and lower traps. We have LS, levator scap. We have the rhomboids, major and minor. Right? We have serratus ant and we have pec minor. Those are the main muscles of the shoulder girdle. So there's our traps. The traps are kind of a really large, broad muscle. And again, like I said, with neck surgery, in order to get into the spine, they have to cut through these. So we've got our upper and we got our middle and we got our lower. They all have specific motions on the scapula based upon their lines of pull. If you look, the upper trap fibers are kind of pulling like that. Middle traps pull in a linear motion. These kind of pull at an angle like that. So they all have distinct lines of pull, right? So we come out here. We've got our rhomboids. We got our levator, right? There's kind of our levator. Levator's a really kind of tiny muscle, but this one's one that really gets kind of tight on people. Which didn't you realize? The line of pulls? Yeah, cutting through muscles. Yep, absolutely. So we're going to do a little exercise right now. I want you guys to all sit upright. I'm going to let you feel the difference between upper trap and levator. I don't know if have I done this before? The stretching difference? I can't remember if I did with you guys or not. I don't remember if I did. Okay. So what I want you to do is pick a hand, whichever hand you want, put it behind your back. So once you have that hand behind your back, take your other hand, grasp the lateral aspect of the opposite side of your head, and just pull your ear to your shoulder. Now don't yank it. Pull it nice and steady and slow. Do you guys feel that stretch? Okay, so what you are feeling there is stretching your upper trap. That's stretching all of that upper trap there. Let's change that. Take the hand that you had behind your back. Now grasp the back of your neck kind of like I'm doing here. Same position with the other hand, overhead. Pull it laterally. Do you feel a different pull? Some of you may get tingles in your hands from this one. You feel a little bit different, right? Okay, so there we're stretching middle scalene. Because what we've done is we've shortened up our upper trap by bringing our hand here. And we're now just stretching this little part here, which is middle scalene. Okay, so same position, one hand up behind the back, grabbing the shoulder. Now, what I want you to do is I want you to take your head, turn your nose 45 degrees to the opposite side of that hand. Put your hand on your forehead and pull your head down. This is by far my favorite stretch. Do you feel that pull? It almost feels like fingers pulling on your spine at that point. Okay, so doing that motion there, you put your traps on slack. You're now pulling down and you're stretching levator scapula. All three of those are real common pathologies to tight and stiff necks and even headaches, especially levator and upper trap, right? If you stretch those, a lot of times, especially if you just stretch out levator, a lot of times that'll relieve headaches. Because you got to think that levator goes the whole way up your spine there. And it does. It kind of feels like three fingers pulling down on your spine when you're stretching it. Some of you are probably just sitting there going, I'm just going to stay like this the rest of the day. So that's feeling the difference between all of those. And that kind of lets you know what's going on. So there's our levator. There's our rhomboids. And remember with rhomboids, you have a major and a minor rhomboid. Even though you don't necessarily differentiate between them, you do have a major and minor rhomboid. We have our serratus, otherwise known as the saw blade muscle, right? Because that kind of looks like a saw blade, and that keeps our scapula attached. If you look at it, that explains why that one works on winging. And then there's our pec minor, our little three-fingered friend that holds on the scapula to the ribs. A lot of times patients will get tight in that pec minor and we'll have to do strumming on the pec minor, where we're actually strumming it like it's a guitar string. And some of you right now, if you kind of let your shoulder go back and you kind of go up at an angle kind of like that, you'll go, oh, that kind of is tight. Probably pec tight. So that kind of all works in here. If you look at the way those all lay over each other, those muscles themselves are going to mobilize that scapula, right? We haven't talked about the rotators yet because the rotators themselves will come into play when we're talking about the actual glenohumeral joint itself. We're mainly just talking about moving the scapula itself. And again, when you look at those muscles, they all have specific lines of pull, right? And even from the front, right, we've got those serratus. So all those lines of pull are going to come into play when we move that scapula. Here's kind of the anterior view, superficial and deep view. We always got those the major pecs laying over it, right? But here's those muscles laying deep. So we've got a force couple going on. I know this is the term that everyone hates because force couples don't make sense to people, right? What I think of when I'm talking about a force couple is you have a bunch of muscles working together to produce a motion. So in order to create this upward rotation, right, you're going to have your traps pulling this way. Your lower traps are going to pull this part of the spine downward, and your serratus is going to make sure that this doesn't wing out. That's going to rotate that and allow us to have upward rotation. So if the problem is the patient doesn't have full shoulder flexion, we need to strengthen upper traps, we need to strengthen lower traps, and we need to strengthen serratus because we need to make sure that they've got full range of motion there in order to get that stuff going. We may also have to stretch the other muscles opposite those. We may have to stretch rhomboids. We may have to stretch mid-traps in order to get some motion going. So here's going into downward rotation, right? Levator scap's is going to pull on just this portion here, right? Right by that, the vertebral border. Rhomboids are going to pull them that way along with a little bit of mid-trap. And then pec minor is going to pull this down and allow it to kind of rotate backwards. That's going to allow for downward rotation. The idea of a force couple is multiple muscles, helping the scapular move, right? We have a force couple in the knee, right? In order to allow the knee to flex, we have our gastroc and our hamstrings working together along with the popliteus to unlock the knee and move it into flexion. That's a force couple as well. They just all kind of pull in the same line. These force couples pull all in different lines to accomplish one motion. Does that make sense to everybody? Good. Okay, so I got someone. You can also allow for reversal of muscle action, right? So with the actual levator scap and with our upper traps, right? They can allow for upward scapular rotation or right side bending, depending upon what we're doing. Our main right side bender obviously is our sternocleidomastoid, but they can help and assist with right side bending when this isn't weak enough by reversing their muscle action. So reversal of muscle action, when we normally talk about a muscle action, right? So let's say we're doing biceps. We're going to move the insertion closer to the origin. When you're doing a reversal of muscle action, the origin is going to move closer to the insertion. There are certain muscles that allow that, and so the force couples can help for allowing that.
Can you say that one more time, Mr. McKeever?
So the reversal of muscle action?
Yes.
Okay. So when you have normal muscle action, the insertion is going to try to move closer to the origin. In the case of the biceps is an excellent way to look at it, right? So the biceps, down here's my insertion, here's my origin. When I flex my elbow, it's trying to move that insertion closer to my origin. In a reversal of muscle action, the origin is moving closer to the insertion.
Okay.
So, right, so down here, right, here's our origin up here. Let me get my annotation, I just put it down. Here's our origin, here's our insertion. In lateral side bending, that origin's moving closer to the insertion versus the other way around, whereas with upward rotation, that insertion is moving closer to the origin.
Okay, got it. Thank you.
Yep, no problem. That's a really complex topic, so it's okay to ask questions about, right? So when you're talking about that, made it a little bit more clear, good. The gastroc can do a reversal of muscle action because the gastroc itself's main job is plantar flexion. But by doing reversal of muscle action, it can actually allow for knee flexion as well. And if somebody's got a paralyzed hamstring, we may work doing knee flexion with the gastroc because that still allows for some functional knee flexion, especially when we're moving the leg around. It's really cool that we do have some of these muscles that can do it. Not all muscles can do reversal of muscle action. A lot of your two joints have trouble doing it. Gastroc's kind of that odd man out. But usually if you have a single joint muscle, there's some reversal of muscle action that can occur. So here's the good news about the shoulder complex. There is no goniometry of the shoulder complex itself. Huzzah. Yay. But you have to be able to, if the boards ask you a question, like they say, your patient, let me get my text up here, and we'll change it to, let's go dark blue. Dark blue sounds good. Your patient is limited to 160 degrees of shoulder flexion. So they don't have the full 180 degrees. How much does the scapula move? So what's the first thing we have to do to this in order to figure that out? What's not 1 inch? It's degree. Remember that. So the first thing we have to do is take out that first 30 degrees, right? Because that first 30 degrees, the scapula doesn't move. So in reality of that shoulder flexion, the glenohumeral movement only occurs in that last 130 degrees. Does that make sense? You need to get this concept because this is an important one. Does everyone understand what I'm saying there? So again, that first 30 degrees, all glenohumeral, right? If I'm going to 130 is about here, right? So that means I'm going, or 160 is about there. So that means that last 130 is glenohumeral with, yes, always minus 30, exactly. Because you're gonna, unless you're talking about extension, then I'm not even going there. They usually don't talk about that. They're gonna talk flexion. So they're gonna say the patient is limited to 160 degrees of shoulder flexion. What is the range of motion of the scapula? So first thing we do, knock out that first 30. So that means they've got 130 degrees of scapulohumeral rhythm going on. The scapula is going to move 1 degree for every 2 degrees that the shoulder moves. So the next thing you're going to do to this is do what? Divide it by, yes, good. Divide it by 2. So that means that the scapula is actually moving how many degrees? In this case here, 65 degrees. Good. So let me try to clear that up just so that it makes sense, because this is important. Because I've seen a lot of questions coming up about this on the boards. Let's go different. So now I'm going to take this question. We're going to delete this out here. Delete. Now I'm limited to 90 degrees. I'm limited to 90 degrees of shoulder flexion. Now it's going to ask how much is the scapula moving with that. So the first thing we have to do is what? Take 30 right away. Good. So minus 30 degrees. That means the shoulder itself is only moving, the scapulohumeral rhythm is only 60 degrees. So how much is the scapula moving then? Good. So the next thing we're going to do is divide that by 2. And you have 30 degrees of scapula movement. Does that make sense? So even though the arm's moving that full 60 degrees to get to 90, the scapula is only moving 30. Okay, let's change this. I'm limited to 30 degrees of shoulder flexion. How much is my scapula moving? None. Good, right? Because 30 degrees is just glenohumeral. I'm good. Right? So at that point, that's kind of, so now let's take this a little further. Your patient has 30 degrees of scapular upward rotation. What is the patient's shoulder flexion? I know it's math. I know it sucks. Okay, so I got 90. So first of all, we have to times it by 2. Good, right? So we're going to times it by 2. So that means we've got, it's equals, not times. So we've got 60 degrees. And then we have, good. I'm seeing 90, which is the right answer, right? Because we have to add that 30 back in. So the actual shoulder is moving 90 degrees. So it's saying they've only got 30 degrees of that upward rotation going on. That means the glenohumeral rhythm is about 60 degrees, but we still have that initial 30 to add back in, so they've got 90 degrees shoulder flexion. Does that make sense? Did anyone lose anybody at that point? So we can do another example if it would help. Do we want another example quick? Okay. All right, so let's get rid of this here. So let's say that the patient has, let's go 40 degrees of scapular upward rotation. Just giving a little bit of white block here. So we have 40 degrees of scapular upward rotation. How much scapulohumeral rhythm do we have? Well, let's take it a step. You're already on it, Dylan. Good job. Let's take it a step at a time. So how many degrees of scapular humeral rhythm do we have? We have to do what to that 40 degrees? Good. We have to multiply by 2. So we have 80 degrees of scapulohumeral. This isn't the official abbreviation. I'm just not typing. Rhythm. Good. Not 808. 80 degrees. Good. Now, good. Multiply times 2. Now we have that initial 30 degrees of just glenoid movement. So we've got to add that back in, which means the total shoulder flexion, we could also do abduction, same concept. They'd have about 110 degrees of total shoulder flexion. Does that help? Okay. That is as complicated of a math problem as you're going to get on your boards. This is probably the hardest math problem you're going to encounter, because there's not a lot of math. If you can get this part of the math problem, you're pretty well good. There's not a lot of math on it, but this is one that they do like to ask questions on. The only thing you have to remember is 1 for every 2 and that first 30 degrees. If you've got that concept down, you're golden. If it takes a little bit, just review it. Obviously, when I put the quizzes up, you're going to have a question or 2 on this, and that's fine. Some of you will get it wrong. Not a biggie. The point of that is so that it beats it into you a little bit to do the simple math. Now, you will not get a calculator. They're not going to ask you, your patient has 31 degrees of scapular upward rotation. They're going to make it easy. It's going to be something like this, where it's 40, it's 30, it's 10, something where it's really easy. No odd number, no 0.5s, no, it's not going to be like the patient has 37.5 degrees of scapular upward rotation. No, it's going to be nice, even numbers for you. And main reason for that is when you're doing a standardized test like the boards are, if you put those odd points in, it can sometimes throw off the actual database in the back end, so they don't want to do that anyway. So that's why they avoid it. All right, so that is the only part of goniometry you really have to know for the scapulohumeral or the shoulder complex itself. Now, we're going to have to know goniometry for the true shoulder when we talk about shoulder flexion, abduction, horizontal AB, and internal external rotation. External internal rotation. But there's no specific goniometry for it, which that should make you guys feel a little bit better. There are manual muscle tests for abduction with upward rotation, elevation, adduction, depression and adduction, adduction and downward rotation, and depression. I'm going to tell you, in the real world, almost no physical therapist or PTA remembers these manual muscle tests. They just don't. I will unless you're a PT or a PTA that deals with manual muscle testing of the shoulder on a regular basis, or you're an upper extremity specialist, so your hand therapists and stuff like that, they remember these tests like that. When you're in the clinic, and even me, I'm going to admit, when I look at these, I have to go back to my book. I have to go back to my manual muscle testing book and relook at positioning for it, just because it's that difficult of a concept. Because scapular abduction with upward rotation is a weird positioning that you have to manual muscle test them in. We are going to practice them in lab. Doesn't mean that your boards are going to ask you a question about them. What your boards would ask you a question about is, if a patient had a 5 out of 5 grade on an elevation test of the scapula, what would you classify that as? Well, that's normal manual muscle testing. They're going to ask you more specific questions about positioning that with the stuff like shoulder flexion, shoulder abduction, internal external rotation, flexion of the knee, hip flexion, stuff like that. The scapulohumeral rhythm manual muscle testing, they're not going to do. We're still going to cover them. So don't think that you don't have to know them. We're going to cover them briefly and really focus on the manual muscle testing the shoulder of the actual true shoulder, if that makes sense. So don't totally freak out. Look at these in your manual muscle testing book, which I don't think I have here. I got it, and I don't remember. It was on my table. Look at them in your manual muscle testing book, but don't totally freak out. That's why if you look at that cheat sheet that I made you, these aren't on that cheat sheet. Because if your PT says, hey, have you done elevation manual muscle testing of the scapula? Well, we're going to do it, but make sure that you understand how they do it, because a lot of times these tests specifically, PTs and PTAs develop their own techniques for, because you'll see that some of the positions that the book says we should do manual muscle testing of the, scapular adduction with downward rotation are really weird hand positions. And so we learn new ways to do it in the real field to kind of get a better feel for it. All right, so that's it with the actual shoulder girdle portion of it. So if I am a betting person that I'm trying to focus on what to know for the shoulder girdle, you need to know that scapulohumeral rhythm. You need to know what upward rotation and downward rotation look like, right? That's looking out here at the tip of the scapula. Is it going up? Is it going down? You need to understand, is this protraction or retraction? Okay, pro, re, okay? Let me ask you something. Is this adduction or abduction? Okay, so I've got an ab, I've got an add. Are we adding to the body or are we taking away from the body? So this is tradition. Well, okay, so here's the deal. Most books, this is adduction because we're bringing everything closer to the body. That's typically abduction. That is why we don't like those terms. Because I could theoretically say, well, technically, the scapula is coming closer to the spine, so technically that's adduction. And whereas here, my scapulas are moving away from the spine, right? So this is the thing. I won't be calling them ab and adduction. I just refuse to call them that. I will call them protraction and retraction. And almost every clinic has moved to that term because it's easy to explain that you're protruding your shoulders and retracting your shoulders. Protruding your shoulders, retracting your shoulders. It's hard to explain to a patient you're ab or adducting and ab or adducting. Does that make sense? So we tend to come up, the same thing with the ankle, right? We've got flexion and extension, but now we've got dorsiflexion, plantar flexion. Just makes it easier to explain to a patient, right? Protraction, right? We're pushing that shoulder and taking that acromial tip going this way. Retraction, we're taking the acromial tip and going that way. So much easier. This is why I wanted to cover it, because even the thumb, you're going to find when we get to the hand. So is that flexion or is that abduction? So going from out here to here. Yes. Good. Right? So a lot of times we call this adduction. One of the books I have calls that flexion. And they call adduction this. And this is what I learned as adduction or opposition. Right? So this is where the books get a little hinky. The upper extremity is one of those that when you're working on it, you have to kind of know who you're dealing with and what the terms they are. Most clinics, again, with the scapula, use pro and re. just because it makes so much more sense. And also it helps if I'm mobilizing the person's scapula. All right, push your shoulder forward, pull your scapular back, pull your shoulder back, push it forward, protract, retract. It makes it easier for the patient. Upward and downward rotation are simple. That's just the way this tip points. Either it points up or it points down, right? Elevation and depression, easy. The spine either goes up or the spine goes down. Spine goes up, spine goes down, right? And then tilt, tip comes out, tip goes down. Now there are some tilts that kind of go this way as well, but that goes along with downward rotation, so don't freak out about that. Tilt is typically talking about that inferior angle of the scapula. And I can't tilt I don't have that ability. No, I can't tilt. I don't have scapular winging, so I can't do it. But tilt is where that inferior angle kind of comes out, and that makes, Erica kind of nauseated. So when you think of tilt, think Erica throwing up, and that'll help you understand it. Does that all kind of make sense to you? Are there any questions that I can help you with on the scapular girdle? If not, we're going to call it for the day. That was pretty much everything we needed to cover today.
I have a question.
Yes.
So if all these muscles that we went over today are part of the shoulder girdle, where does the rotator cuff come in at?
The rotator cuff comes in because the next lesson we're going to talk about is the actual glenohumeral or the shoulder joint.
Okay.
The rotator cuff. So typically, remember how we talked about intrinsic and extrinsic of the foot?
Yes.
A lot of times you can almost think of this like the rotator cuff are intrinsic muscles of the shoulder, whereas these muscles are the extrinsic muscles of the shoulder.
Okay, cool.
Does that help a little bit?
Yeah, it does. Thank you.
The rotator cuff are going to primarily work on just the humeral head.
Mr. McKeever?
Yes.
My computer died during the testing of the shoulder complex. I hope I didn't do too much, but could you just go over the math that was involved or how to test that or whatever?
Okay, for the goniometry and stuff like that?
Yeah, I know you mentioned some with boards. I got the 40 degrees, the 80 degrees, and 110. I just didn't understand what was going on with all that.
Okay, so let me bring my whiteboard back up here because that'll help. I can do that one more time. So let me clear my whiteboard here. Clear all drawings. There we go. All right, so one of the things I said is you're not going to have any specific manual muscle tests of the, or not manual muscle tests, any specific goniometry of the shoulder girdle, right? The shoulder complex itself. You're going to only have goniometry of the actual shoulder or the glenohumeral joint. The only thing you have to know is that 1-to-2 ratio. So let me bring up my text here. So again, that 1-to-2 ratio, meaning that, actually 2-to-1 is probably the better way of putting it. Meaning that for every 2 degrees, the glenohumeral joint flexes or abducts, the actual upward rotation of the scapula goes up by 1 degree. So that's kind of what we were talking about with this. And what I was saying is the boards are going to ask you a question where they'll say, we'll do another example of it. Let me think. So let's say that they'll say that your patient has 170 degrees of shoulder abduction. And the question is, what is the upward rotation of the scapula? So that'll be the question. So the patient's got 170 degrees. They've almost got full range of motion of the shoulder. What's the upward rotation of the scapula that goes along with it? Well, the first thing you've got to take out of that 170 degrees is that 30 degrees of just glenohumeral movement. So that's going to leave you with 140 degrees of combined glenohumeral, scapulohumeral movement. So that means that 30 degrees is here. Now my scapula's got to move with my glenohumeral shoulder, right? Or actually, I'm doing abduction, so I'm not here.
The first 30 degrees is all glenohumeral.
Is all in that the glenoid fossa. There's nothing going on at the scapula itself. Once I get past that 30 degrees, now my scapula has to upwardly rotate in order to allow me to move.
Gotcha.
And so if it's asking you what the upward rotation of the scapula is, you've got to take that 30 degrees out, and now you've got a total of combined 140 movement. So in that 140 degrees, for every 2 degrees that I go up with the glenoid fossa, the scapula has to upwardly rotate by 1 degree. So you're just going to take that 140, divide it by 2, and that means that the scapula itself is moving up by 70 degrees. Does that make sense?
Yeah, that makes perfect sense. Thank you.
Yeah, it really is simple math, but it's going to trick you because you're going to get all caught up in the math. And if you just simplify it, it makes it easy for you. Just remember that for every 2 degrees, this goes up by 1. And then you've got it.
That's after the initial 30 degrees.
After the initial 30, yep. Right, and like I said, so if I lock on that shoulder, I only have about 30 degrees of abduction that I can do. As soon as I start letting off, now I can start, and I can even lock here. So maybe I want to limit the patient, and maybe the doc says that they're only allowed to have 90 degrees of shoulder abduction after the surgery. Well, we can come in and stabilize that and keep them from getting more than 90 degrees just by keeping that scapula from moving. And a lot of times they may do that. They may put a sling on that kind of limits that scapula so it can't upwardly rotate.
Cool. Yeah, that helps a lot. Thanks.
Yeah, no problem. Any other questions? There's no such thing as a silly question, only the one that's not asked. Are we all good? All right. So let's call it a day. So tomorrow we're going to talk about the shoulder itself, and we're going to get a little bit into the manual muscle testing and the range of motion of the shoulder. You are going to have a little bit of homework tomorrow, I'm going to warn you. And the homework is going to be checking some of your family members' shoulders to see if you can feel and get on that scapula, feel that moving around. But that's for tomorrow. It's not for tonight. So that's it. Then I'm pretty much done.